morning, everybody. We're back. It's Monday, September 27th. I think I have that right. It's great to be here again. I was just watching the slides scrolling by. And again, I know I said this last week, it's just really great to see all the photos of people that are attending. I know that there's so many more. We have, like I said, over 350 people who have registered for this conference this year, which is fantastic. But just so great to see all those different faces and imagine who all is out there. So just a few items we want to address this morning before we move into our first session. So as a reminder, we talked about this all last week, use the Q&A function. I'm guessing you all are getting pretty good at that at this point, but just want to remind you of that. We will be doing a prize drawing at the end of today, like we have been the other days. So please do stay tuned and hang on for those. And also you should have received last week, after last week's sessions, a link to provide feedback. I know you do this for all sorts of other things, and we're the same. We really want to know what worked, what didn't, and just ways that you value this conference and things that we could do to improve. It really helps quite a bit. So please do take a look for that. We'll be sending out another one at the end of this week, which will have just the sessions for this week. So the link that you received last week is just for those sessions. So please do take a look for that. And it should be, I think you probably received it on Wednesday. So take a look for that. And I wanted to share a couple items that you might be interested in. I am going to share my screen. One of them is some information that might be useful to you. And we just want to make sure you're aware of. So this is the Covering Wisconsin webpage. You're probably familiar with it, especially related to the conference. I wanted to point out that there are resources that we've newly made available. Obviously, there's lots of resources here under the Resources tab. If you go to the 2021 Media Toolkit, you'll find resources that you can freely download and print in a variety of different formats and in just different options you can choose from. There will be more being posted in the days to come, but these are already available. And like I said, free to download and use however you'd like. And please do share that with others in your community. And of course, as always, feedback is welcome. If there's something that you'd like to see, please let us know. And then if we go back to the homepage, I also wanted to share more information about a resource called the Connector Tool. I think a lot of you are probably familiar with this tool, but some of you may be new to it. Really, it's a way, how do we help consumers in the state and other professionals find you all? How do we help connect them to you? And we know that can be done in a lot of different ways. Outreach, of course, is a big one. Promotions, a big one. Just the creating a network in your local community, talking to other partners is a big one too. But this is one other way. If you go to the website and on the homepage, on the left there is what says Enroll. If you click on that, this brings you to the Connector Tool. And this is actually a resource that is made available nationwide through a group called Young Invincibles. It was originally created through, I think, Enroll America, and then handed over to Young Invincibles. And we are one of many groups around the country that use it. And it's pretty simple. Whomever is looking for help, you enter in your zip code, and then you can select how far away you want the distance you're open to finding help. And then you can also select languages. And here, there's even more options than have been available in the past. Recognizing that we're still doing a lot of assistance, if not the majority of assistance virtually, not only in person, but telephone or Zoom. So I'll just put an example. So located here in Dane County, you scroll on that, and then you scroll down and you see that there are some options there. And then some have the option to schedule online covering Wisconsin. Always make sure that we can not only provide our phone number where people can call, but also click on that to actually schedule directly online. But to be in the connector tool, you don't have to be, you don't have to provide an online scheduling option. It can be, you just make sure your phone number and your address are in there for people to find you. And that's the most important thing. So in your registration, you indicated that you are providing enrollment assistance, and we'll be looking at that and trying to make sure you're listed in there so there won't be anything more that you need to do unless we have questions. But if you didn't complete that, or if you know other groups that didn't register for the conference but do provide enrollment assistance, just go to our contact us and provide that information, let us know. The main thing is that this enrollment assistance has to be for Marketplace and Medicaid. It has to be freely available to the consumer and really provided for anybody. So we know that sometimes enrollment assisters really focus just on their clientele, which is fine and great. We really want to make sure that this is publicly available. So if somebody is searching, that they know that they reach out to you, that you'll be able to assist them. And then just some other information that's provided along with the connector tool. There are some videos that are both for you and consumers in a variety of different languages to just help you understand how to use the connector tool. It's really, really quick. And there's also information about that we provide about what you need to bring for your appointment. And then just some information about what is a navigator. And related to this, I wanted to also mention that one of the resources that Covering Wisconsin connects to quite a bit in our promotions is 211. If you're not familiar with 211, it's through United Way of Wisconsin. And they're really a kind of a one-stop shop of helping the community connect to resources. And so not just health insurance, but a whole manner of food, housing, other security related programs. So it's great to be familiar with 211. Know that when the information that's in the connector tool, we also make sure 211 is up to date on. They have their own ways of adding things to their databases, but we provide them with the latest information about who's providing enrollment assistance. So again, that's a great way to make sure your information is in 211 as well. And one other thing related to the connector tool is I'm going to stop sharing this screen, and I'm going to share one other resource in case you'd like a little bit more information about what the connector tool is. So I mentioned the connector tool is a resource provided and hosted by Young Invincibles as a national organization. They also are providing training opportunities this week. It's a lot of training, but there's a lot of information to learn. Part of their summit, as it's called here, does overlap with our last day of our conference. So that's a bummer, but I did want to mention part of their agenda is they have a session on Wednesday, September 29th on the connector tool. It is 2:30 Central Time, and I believe it's only about a half an hour session where they'll talk about what the connector tool is, and how to use it. So that'll be a nice, more in-depth explanation. But for sure, if it's something that's specific to Wisconsin, you're really interested in learning more about, feel free to use that contact us feature on our website to ask for more information. And you can find their full agenda clicking on this button, which we'll make available through our conference page. So I just wanted to raise awareness about that. So I'm going to stop sharing my screen. And I think that is all that I wanted to share this morning. Again, welcome everybody. I'm really pleased to have you all here. And I guess we could probably go ahead and just get transitioned into our next session. I'm really happy to have Anna Van Spankeren and Julia Garvey hosting this session. They are the moderators and the presenters of this session, which is awesome. They have just been expert senior navigators doing this work pretty much from the beginning, and are often the go-to people in the state for those complex case questions. Adam is the Navigator Program Manager for Covering Wisconsin, and Julia Garvey is at Partnership Community Health Center and has been a navigator and an enrollment assister again, pretty much since the beginning. And we're so pleased to have them. So I will kick it over to you guys, and hope everybody enjoys the session.
Thanks, Allison.
So now we're going to try and do the graceful transition into PowerPoint.
Yep.
And Allison, I heard you describe us as senior. I would, as I'm getting older, I'd prefer that we call myself experienced. How's that?
Awesome. I
I'm
take
getting
it back.
way too close.
Senior.
Doesn't matter to me yet.
Adam, tell me when we're sharing.
I can see your screen.
And you can see my Healthcare.gov.
I cannot see anything but the PowerPoint. It just needs to be put into slideshow.
We're getting there. We've been doing this for 2 years and it's still awkward. Okay, we're up and going.
Yep, looks good.
All right, good morning, everybody. So this presentation is going to look a little bit different. There's a lot of other trainings that do a great job of providing policy, but it's really hard to quantify the relationship building, the listening, the interviewing, what's described as soft skills, which really are the skills that we use to make enrollment effective, both in terms of actually enrolling people into the correct health insurance program, but most importantly, building a relationship in which people feel heard, served, and valued. You know, when we start into an application, we don't really know which direction we're going, and consumers don't know programs. People calling, asking for help are often in vulnerable situations, and we have the opportunity to make enrolling into health insurance an entirely pleasant experience.
Yeah, as pleasant as it can be anyway. Yeah, we're
right.
Like Julia said, we're not going to drill you on program rules. You're always going to need to look them up sometimes. You know where to get them. We've had plenty of those kinds of sessions at this conference and others. But actually how to do this work and how to do this work well is what Julia and I want to leave you with.
So I've been doing this work since 2014. That's 8 years of making mistakes and hearing things that are effective. And I hope to share some of that with you today.
Yeah, Allison did a nice job. She saved us from, I think, half the introduction at least. I started off, I've been doing this work, or at least adjacent to this work, for almost 16 years, which is really weird to say. I started off at ABC for Health, working on publications and health reform policy and all of that, before going to DHS and helping to teach some of the Medicaid transitions that were part of the ACA. And I've been at Covering Wisconsin since 2016 doing this work.
Actually, Adam, it's funny what you say that when you teach, you said you were teaching things through DHS. The first time I met you was up in Green Bay when you were working for DHS doing a presentation, and I thought you spoke really fast then, and I'm going to call you out on it later in our, our presentation.
Fine. There's always room for growth.
You've got so much to say. So today we're going to learn how to work smarter. We're going to increase our efficiency by correctly assessing households and programs and heading off in the right direction intentionally.
Right. And we're going to teach some interview techniques, or at least how to do the interviewing that's important for this work, because it is an interview. You are asking questions and patiently listening to answers. You're saying, hey, can you go back to that, elaborate on things, because you need that information to help somebody.
And nobody understands health insurance, and especially in this day and age where I haven't seen anybody in my office for almost 2 years. So I don't have the benefit of using the visual aids that I love to show people. We've really got to express ourselves verbally, clearly, and make health insurance understandable so that we're not just pushing buttons on an application, or as Adam likes to call the Healthcare.gov call center, calling the application. What we do really brings health insurance to a new light for people.
Yeah, and I thought about it, Julie. It's not just calling the application, because calling the application, if it were automated, it'd actually be more useful, because you wouldn't have somebody tripping over their words or trying to give extra information incorrectly. Yes, we want improved outcomes. That's the goal of doing this work, of doing it well. For the consumer, we want you to feel confident teaching consumers so they can feel confident. They will feel confident in using their health insurance. They will feel confident going to the doctor. They will start paying attention to their health and their coverage. And really, it's going to improve many things for them over the course of years if you can do this right.
So the whole point of enrolling people into health insurance is allowing them to access care. If I could cross stitch, I would put this in a frame in my office. We are humans talking to other humans who are sick, scared, in debt, don't understand health insurance, have a political bias, have had bad experiences with health insurance programs, have a major problem with their coverage, have been bounced from agency to agency, don't know what programs are available, and can't articulate what they need. And lest you think that sounds dramatic, I want to share with you an example from our office. One of our certified application counselors, Bridget, answered the phone a couple of weeks ago and had a conversation with Ron. And this example fully prepares us for what we're going to be talking today, because she did everything right with Ron. So Ron had been laid off his job of 43 years, and he had been experiencing a host of challenges. He was not able to get through to unemployment. He felt he had been let go unjustly from his job. He's talked to multiple people from different agencies, including some questions about health insurance. But his wife has multiple sclerosis and hasn't worked for the last 12 years, and she has very expensive medication. And his biggest concern and fear is that she not get her prescriptions and that they go even more deeply into debt paying for health care without having insurance. So Bridget listened to all of his concerns, and it took quite a while. He had a lot of stuff on his shoulders. She took notes, and what she understood and heard from all of that, and keep in mind that we're distilling all of the, all the emotions and facts that people lay out and asking clarifying questions, is that as of September 1, he was not going to have any income. His job, he had received his last check, unemployment wasn't coming through. So what nobody had identified prior to this, talking to him about health insurance programs that he could enroll in and start and pay for and start a whole new cycle of out-of-pocket costs for the last half of the year, was that he was eligible for Badger Care as of September 1. Now, again, this is a man who can't imagine himself being a recipient of a Medicaid program, but his main concern was getting health coverage for his wife, getting help paying for his prescriptions. And because Bridget had built trust with this man, and she helped explain programs and what a benefit Badger Care would be to him and his wife, he got enrolled in Badger Care and Food Share starting September 1.
Right, Julia, thinking about that statement that you want to cross stitch, it's very easy, including in the example you just gave, for somebody to check all of those boxes. Like that's almost everybody who's been bounced back and forth, who had a problem, who are dealing with health issues right when they need help. So that is exactly what this work is. So if that sounded familiar, some of this should as well. People who have just dipped their toe in, they filled out the application and then they saw $635 and didn't realize that that was the actual tax credit. You know, that would make me shut down my computer. I know that. They're confused. And anytime somebody has had a bad experience, especially with Medicaid or the marketplace in the past, they're not going to want to do it again. And we can help with that. Especially people who said, I've been denied in the past. That might have been 3-4 years ago in a lot of cases. And they just have been reluctant to start over, and that's where we can help. And we do that by getting to know the applicant. So applicant calls you, consumer calls you. We don't know that they're an applicant yet, actually. First thing I do always is grab a notepad or a notebook. Even if the first thing I write down is actually something that I'm saying until I get my brain going again, I tend to write down, I'm writing anything they say that could be important. And we'll talk about what some of that information is, but I'm listening to the consumer. First things first, this is the order that I would love every consumer interview to go in, talking about what's currently going on, talking about recently, the past 3 months, especially for backdating, and then what changes they anticipate in the future. So somebody right now, what made them pick up the phone? That there's always something that said, hey, I need health insurance. And usually that's going to be the most important thing to them. And the thing that you're going to want to come back to again and again during the appointment, because it'll help them focus, and you'll very much understand them and why they think they need coverage and why they do need coverage. So a lot of times that's that they lost their coverage, lost their job, or they're planning transition in the future. Maybe they're moving, maybe they're going to retire. We're seeing a lot more of that now than ever, and people want to plan for the future. But to do this and to assess people correctly, first we want to know what happened most recently. They're going to launch into what's going on today. Ideally, we're going to write all that down. We're going to get people's information, and then what happened recently? When did you lose your job? That's if somebody says I lost my job, I'm going to say when, and they're going to say in July, and I'm going to say when in July, because that could be important. And you just kind of coax them to give you more and more information. So by the time you're done, you have a really good idea of not only this person, who they are, what they value, but also the direction you're going to need to go to help them. Okay. So yeah, guided conversations, that's what you're doing. You are gently steering the consumer toward key pieces of information. You want to listen, you want to be patient. They're going to launch into, again, whatever their immediate concern is. Maybe it's not even health insurance, but we listen and we start there, because again, that's going to teach you what they value, and that's going to teach you how to help that particular consumer. So if somebody turning 19 or 26, we know those are key ages for Medicaid and for Marketplace. Is somebody turning 65, Medicare, that you want to know who's in the house. Typically, that's the main thing you start with. You want to know how many people are in this house, how old are they? That's going to be half the battle in looking at programs. And the other half is basically who you filing taxes with. And we know that. You guys have had a lot of sessions on program rules and policy, and that is a start. So if you can get those pieces of information early, then you can start thinking about how you're going to help them. And then, of course, immigration status. It's very important that you get that early if you can, because it determines also if they can go to the market, or if they can go to Medicaid first. They haven't been here for 5 years but have the right status, or if they go to the Marketplace because they haven't been here for 5 years yet. That will answer a number of questions just right off the bat.
And I'm going to jump in here with something. I feel like I've talked to a couple of groups of people recently, lots and lots of people who are considering retirement, who have, looked at the last couple of years and said, I think it's time to do things that are enjoyable. This last 18 months has been too stressful, and they're planning for, what can I even afford to retire before Medicare starts. Another age group is young adults who are accessing care more often. I think there's such a greater conversation around accessing behavioral health care these days, and accessing care affordably when you're on a parent's insurance. I've talked to a lot of young adults who are on mom and dad's insurance, but they've said you need to pay your out-of-pocket costs. A parent's high deductible health insurance plan, if you are a college student working very few hours, where you might actually be eligible for Badger Care on your own if your parents didn't claim you as a tax dependent, or even on the marketplace if you're working at a job that doesn't offer you coverage, can be so much more of an affordable way for them to take on health insurance on their own, have more agency in their care, and probably do it more affordably.
Yeah, and that college student example hits close to home for me, Julia, because I was working on all these different, publications, learning these policies and program rules. One day it clicked, was in college, that I was kind of describing myself, and I got on Badger Care the next day because I didn't think of myself in that population, even though I was looking it right in the face.
Yeah.
So each household is unique. That's you can tell that just by the many examples we've been giving so far, just by that your own household is unique. But first thing, you want to know what is, again, that reason that they're calling, and usually that's a change. Is did somebody lose their job? But is their income fluctuating? Is it going from up here to down here? Did they just lose their job? Is unemployment starting? Or is somebody starting a job in October and they want insurance until theirs starts? So you're trying to figure out what the change is that they're trying to prepare for, or what it was that they now need help from. And you want to make sure you are not just, you're talking to an individual and that person is a representative of that household, but you want to make sure you're looking at everybody in the whole family, because depending on their immigration status or who's tax dependent with whom, who's eating food with whom, in some cases for food share, it really changes what people are going to have for coverage in the end. You can help the whole household. You will help the whole household, but you might need to explain very different rules based on where everybody ends up, and help people feel comfortable with that. So,
yeah, and people have no idea what the rules are either. They don't know when they call you who might be eligible for what. I kind of jumped in there. I just wanted to say that when I first started doing this work, I had a checklist for myself of, are you married? How old is everybody in the household? I had a checklist to go through, and I found that only captured some of the information, and these conversations that we have fill in the gaps. And I very rarely remembered to ask questions about some of the things that we've got listed down below. And I've always said that the way that I learn best is by making mistakes, and I still make mistakes.
Right. Those are the ones that stick with you. When you learn the rule, you learn the fix. You remember that consumer situation. Consumers, they don't know what programs are even out there, so that they can't imagine. They don't know what information you need yet. So it's best to just let them elaborate on their situation, and then, hey, can you please go back to that? I didn't catch that. And you're taking notes the whole time.
You used a phrase that I liked before. I'm going to remind you of. You said you invite them to share what they need to share.
Right. Yeah. Thank you. That was profound when I said it. That was right. No, you invite them to share what they need to share is 100% right. You are making them comfortable. You're building that rapport with them so they can share what they feel they need to share, get off their chest, and also what they need, what you need to help get them onto a program.
So spending all that time and in the front end, having conversations with people and understanding their household makeup makes a lot of sense for me, because once I identify a path, I can start going down that enrollment path with much greater efficiency rather than blindly. The Healthcare.gov application will screen for everything. That they've said for years, there's no wrong door. But for me, it's a wrong door to start down a path and discover at the eligibility that I should have made another choice. So spending all this time up front really helps me make a very efficient path and a plan. So if I, in my conversation, determine that someone might be eligible for Medicaid, I'm not going to apply in the marketplace to get that Medicaid determination. I'll go directly to either Access or a phone application. If there's a chance that someone might be eligible for Medicaid, someone's on the brink, or I don't really understand how they're going to count income, I will apply for Medicaid always. Always exhaust all Medicaid options before I go to the marketplace. But if I've exhausted all Medicaid options and I know 100% sure that your income is too high, you don't have a backdate opportunity, I'll go directly to the marketplace for that determination. And there are all kinds of ways right now to get people enrolled in the marketplace through the variety of SEPs and little tricks to get people on. There shouldn't be anybody right now, even though there's no technical SEP, that FEMA SEP will get people in the door.
Right.
But for houses with mixed eligibility, where you think, well, maybe someone in the household is going to be marketplace eligible, but I think that someone in your household, like a child, would be eligible for Medicaid, it's more efficient for me to do it all on Healthcare.gov. That determination will go from Healthcare.gov to the state, and then I'll follow up in about a week with the IM agency to call and see if they've got that information transferred from the marketplace. They call it, they get their FFM exchange, and they'll get that information, and we can call and clean anything up that might look. By the way, what they see at the IM agencies from the marketplace is messy. I don't know. We will touch on that in the advanced topics of Medicaid, but it's never really very clear to them what's going on. So I always do follow up with the IM agency to say, what are you seeing on your end? Do you need any more information?
That's exactly what I say too, Julia. What are you seeing in the system when I'm talking to an IM worker? Because I want to know. They have access also to other information that the consumer might have forgot about. They're coming back from different databases and things like that. But by and large, when you're helping somebody, if you've done your homework, if you've taken notes while they talk, it shouldn't be a mystery. You should know, in most cases, know what they're going to have in the end. Sometimes there'll be, those edge cases Julia was describing, where you might not be sure somebody's right around that threshold. You need to try for Medicaid and stuff. But for most people, you should feel very confident before you boot up Access or before you open a marketplace application.
So my first step in applying for health insurance through the marketplace is to make for sure I've exhausted all of my Medicaid options first. I work at a community health center. We have people scheduled, and when they call, if I didn't answer the phone, it might appear in my schedule as someone needs a marketplace enrollment. But my first thing that I do is always to say, again, what's happening now, but what happened 3 months ago. So in this scenario, Brad had applied for Badger Care on his own and was denied. And he thought he was going to be marketplace eligible. But what he had done, of course, is called in September and just reported his September income, which was over income, because Brad doesn't know programs and numbers and eligibility. But in talking to him, even though I knew that he had been denied Medicaid, I look at my little calendar, my desk is strewn with things, and say, okay, 3 months back, what were you doing? And discovered that he had this, window of opportunity that made him eligible for Badger Care. So we just called back to the IM agency and let them know that he, in fact, didn't have income. We're requesting the backdate of coverage to May. And you can do that, by the way, even though the Access application says, do you have any medical bills for the past 3 months? You can request a backdate because someone is income eligible. And in fact, he was, and we got him onto Badger Care.
Right. I know you're going to underscore that in your advanced Medicaid tips and tricks as well. But yeah, nobody can say you can't apply for a given month. Everybody has that right all the time. So it can be confusing when someone's on their own. They'll say, no, I didn't have any medical bills. But that question is related directly to backdating. Yes, it could be for medical bills, but in this case, in this very new environment we've been in the past couple of years, that just opens the door to getting on a program and being eligible for having coverage for a long time.
So I talk to a lot of young adults as part of our outreach that we do in the community. We work with a local technical college. I've ingrained my 22-year-old daughter to talk about health insurance to all her friends. I talk to a lot of young adults and I make assumptions based on that, which sometimes are incorrect. So I did talk to Tim, who was 21, who needed health insurance. And for some reason, I was thinking about income and started to look at my handy dandy chart. And by the way, I have strewn about my desk and in my drawers all these tools that I find super valuable. To me, this is the most valuable FPL chart that is around, and the link to this is live. It shows you not only the monthly amounts, but the yearly amounts, all the way, I can't capture it on this screen, but all the way up to 400%, when 400% used to be the cutoff. In looking at this chart, talking about income with him, it reminded me over here to look and think about household size. And it occurred to me to ask Tim, who's 21, are you married? And in fact, Tim is married. He has a pregnant wife and a child. So this 21-year-old, who I assumed was a single basement dweller without insurance, is a family man. And that completely changes the household and their coverage options. So he had a job where everybody was covered by his employer when he lost that coverage. So now nobody has health insurance. Pregnant wife and child will be eligible for Badger Care. And he is collecting unemployment, I think. I don't remember his income, but he will enroll in the marketplace. Furthermore, as you're gathering information, because he's receiving unemployment, you know that and this was a couple months ago, when we were able to report that he was receiving unemployment on the marketplace, that's going to lower that benchmark plan to 0 for him and lower his cost sharing. So here's a scenario too, where because I first incorrectly and then finally unraveled the story, this is a scenario where I would apply on Healthcare.gov for everybody, because it will send that information for the wife and child to the state. We'll be able to get Tim enrolled in his marketplace coverage right away, and then follow up with the IM agency to make for sure that they've got everything that they need for mom and his child.
You know, I love that example, Julia. It reminds us that you can be a veteran at this work. You could be a CAC for 6-7 years, a navigator that whole time as well. And you will start to get complacent. You will start, after your 100th person, start to think, oh yeah, I know what this is going to be. And it's important to remember how you started learning this, the order in which you're interviewing and the information you're collecting before you make any kind of assumption. And I've done it as well. It's very easy to do. So just remember to check your preconceptions and listen.
You know, I always thought that most likely the application will catch you. He would have said at some point, hey, what about my wife? But to have this information and make a good plan about, well, all right, this is what we're going to do.
Right. And this will happen to you. I just want to say that's a good point, Julia. Yes, if you make an assumption and start the application will catch you. You won't feel great about it though. You'll be embarrassed, and it'll be a good lesson for you. But everybody's going to do it at one point. So
I once assumed a woman was a widow, and we got to the end of the application, and I actually, helped her choose a plan, and we were done. And she said, "Now what about my husband?" And I don't know what had happened that I thought that she was a widow. That was hard to back out of. All right, it's time for our first poll question. Let's put this up right now, and I think Mike, you're going to share this.
Yep, so that should be live now and all good to go. So we'll give about a minute for that, and then afterwards we can go ahead and discuss that and move on.
Yeah,
Adam,
I'll go ahead and read that.
This through?
Yeah. So what do you find most difficult when working with consumers? Building trust with the consumer, speaking in plain language or communicating effectively, collecting the information that you need to complete an application, or discussing complex health coverage concepts?
All right, Adam, do you want to expound even without answers? Because we can come back to that.
Sure. If I'd like to see the answers. Well, my supposition would be that it would be very spread out, which would make sense. So discussing complex health concepts, that would have been the other thing. I assumed that one would have the edge, but I did expect it to be a little bit more spread out than that. But the important thing that I just want people to take away from this is those things are all interwoven. Some of them you could basically say are the same thing even. And that's different ways of looking at this work. And if I like to link the last one and the first one because they are the most dissimilar. Building trust with the consumer and discussing complex health coverage concepts. If you've taken the time, if you've built the trust with the consumer, that last one's going to be a lot easier because not only are you going to be more comfortable, you're going to take things a little bit slower. They will feel comfortable asking you to slow down, asking you for the piece of information that they missed. And that will really improve those outcomes.
Okay, let's move on. So this has been a strange time. Like I said, I haven't seen anybody in my office face to face for about 18 months. And we're not going to be seeing people in our offices for enrollment appointments for the foreseeable future. So we've really had to hone our verbal skills. And one of, I think, the most effective ways to do this is just to slow down. And Adam, I'm going to point to you again, because people who know the work that they do really well just blaze on through. And we have to remember that consumers are hearing this language maybe for the first time, or if they've heard it before, maybe not understood it. And it's less important that we get a bunch of content out as it is to make what we say really effectively heard and understood. And slowing down our speech pattern when you're on the phone and you don't have the ability to watch for their comprehension it's really important.
Thanks, Julie. That's not nearly as hard as Stephanie Sievers, our health insurance literacy person, grills me before I'm on an important discussion. Yeah, because I'm guilty of that for sure. Always getting better.
Yes, you are. So don't use acronyms. ACA, APTC, there's all kinds of acronyms related to our work, our industry language. Again, consumers don't know that. And in fact, I've even started, I remember they used to say, don't call the tax credit a subsidy, but people understand subsidy. People understand, I'm getting money to help me pay for something, and it's like a subsidy. I've changed my language since I can't point to a tax credit number. I sometimes even direct people to take out, I'll always take out a piece of paper and pencil and take some notes with me, because I want you to understand some of these concepts, and it's easier, I think, if you write down some numbers. But I've simplified my language, and then I repeat concepts a lot. Part of it's just the way my speech patterns go. But if you hear me say tax credit 6 times before we get to the end of the application and talk about this tax credit actually having tax filing implications, you're starting to link that savings as an actual tax credit that has impact when you do your taxes. Then I can remind you, you're going to get a statement in the mail in January from the health insurance marketplace that you need to use when you do your taxes. So I sprinkle through those weird concepts that are new to people throughout our whole discussion.
I touched on this briefly when we were talking about that whole question, is you are giving people permission to ask for clarification. Like I also give people permission to tell me just straight out to slow down. I also want them to feel safe and comfortable in saying, hey, I don't know what that means. Can you explain that a different way? And if you get really good at this, you will start thinking about how people understand things. You will start reframing concepts like the way Julia just did with the tax credit. Advanced premium tax credit, as soon as you throw the word advance on there, they start wondering what that is and how it works. But you can replace that with subsidy pretty easily. Or you could boil it down even further to say, this is how much you're going to save each month on your health insurance. And that makes sense to people, even though it took a whole sentence.
Can I stop you before we go on to the next one?
Yeah,
because
sure, yeah.
I'm going to get to a point here pretty soon where I ask people to share screens. I also tell people how to access the preview tool on the website. So even if I'm not Zoom sharing, before I get to the screen where it shows the tax credit, I say, okay, the next number you see is going to be the amount that you save on your premium, not what you're going to pay. I can't tell you how many people get to that number and their brain shuts off because they see this number and they think, I can't afford that. I want you to, continue with me and understand that this is going to be a savings. It's a much better thing to see $635 right away as your savings rather than what you think you might have to pay.
Yeah, Julia mentioned asking people to take notes. A lot of the consumers that, especially if you're doing this over the phone, I find, but a lot of the consumers just in general, they come ready with a notepad. They're already thinking, I want to understand this, which is great. That is the best place to start, absolutely. But people who take notes, they're also more likely to ask for clarification on things because they're going to write it down. And as they write it, they're going to think, do I understand this? And that's where you go back to asking for clarification or repeating something. And as soon as a consumer understands that concept, they will start repeating it back to you, which we'll talk about in just a second. Giving examples with stories. I try to explain health insurance because I look at a person's situation. I talk to them. They came in with foot pain and they know they want to go to the doctor for that. As I'm thinking about that, as we work through the application, and when we get to the end, I'm thinking, okay, I want this person to understand what going to an appointment will be like. I want them to say, okay, you're going to walk into the clinic, you're going to pay this amount, that's the copay. And then after that, you're going to see the doctor, you're going to get a medication probably, and you're going to pay this much for that medication. And then you're going to get a statement in the mail. It's going to say, this is not a bill, but it is absolutely a bill, and you should work with them on payment plan if you need to. But I just want them to be fully aware of the expenses of the health insurance because then they're going to feel a lot more comfortable using it. And then I was talking about this with people taking notes, is they will start explaining things or repeating things in a way that makes sense to them because you've explained it, because you've repeated it. They're going to say, well, does that mean? And then you will be asking people before you know it to kind of repeat things back to you, but they'll be doing it just on their own as well. So you'll know that you're getting your point across.
And if you can send me an email, you can open a Zoom link. And I've found great success in the last 18 months asking people to join me on Zoom. Doesn't matter if they don't have a camera. If I can share the actual application with you and you can see that I'm typing your name right, you can see I'm capturing your address and social security number correctly. Most importantly, when we get to plan selection, where you can see the numbers and I can show you comparisons, it makes a huge difference in the way that people are able to comprehend. All right, so part of what we need to do is gathering household information is doing the math, and it's really hard for people to count their income. There are a lot of people who don't really understand what their gross income is. And so I ask people with their little notepad and paper to identify what their hourly wage is, how long they've worked at that particular job. Did you have other jobs in the year? Can you put your finger on pay stubs or look them up? Because actually being able to see the dates that you were paid might really help us get into Medicaid with a back date if we can really understand your past 3-month income. I ask people to do the math with me so that I'm not telling you what you make. I want you to do it with me and that we come to an agreement that this is a good estimation of your income.
Right. I really like the way that you said that, Julia. We'll expand on that a little bit here. So remember, you're talking to the consumer, you're listening, you're taking notes. So you're looking at one piece of information you want to draw out is their monthly income. You want to know all of their income. You're going to understand all of their income by the time you're done, but monthly income, that's going to tell you if they can get on Badger Care most of the time. The exception to that obviously is gap filling, which I'm sure the people who are have been doing this even 2 years have probably heard that, where if you want, you can have the IM agency look at your annual income instead of your monthly and divide it by 12. So you can get on Badger Care if you have a very, high income 3 months, but the rest of the year you didn't work. You can use gap filling to get on Badger Care. But knowing what that looks like, so you're looking at monthly income, but you're also going, okay, this is another one of those places where you can make an assumption. Hey, I make this much money. Don't just assume they're going to make that much money for the rest of the year. They may know of a change that's coming up and will affect that number a lot. So the marketplace is looking at that estimate of yearly income. So you're screening for all those jobs, you're screening for changes, other sources of income, no worries. People who are self-employed, but referring to last year's taxes, you only do that if they're going to be at the job, same hours, same rate of pay. That typically, I don't see that a lot for people who are, when I'm just doing non-self-employed people, when I'm just doing most applications, I'm not usually using last year's taxes, don't need them. But I do get asked all the time, should I bring last year's taxes? And I tell people to bring whatever makes them feel comfortable. That said, you can still help a consumer if they don't have all the information. Don't hesitate because of that. Don't, they might want to run home and say, hey, can I get this? Or over the phone is a little easier because yes, you can call me back as soon as you found that thing. But generally speaking, they don't have to know all the information for you to start working them through what Julia was just talking about, getting that information, then counting that income, multiplying it out for the year, figuring out a good estimate. Especially for the marketplace, you're projecting the year ahead of you. So it is your best guess. It might be a really, really good guess. You want it to be, but they can't say that that's absolutely wrong either. And then with income, you're going to come across situations where people have pretty thorny income situations, and you may have to refer people to tax assistants. The one that the marketplace tells us, or I should say CMS tells us to refer to, is the volunteer income tax assistance sites, which is VITA. You've probably heard that, which is free tax help, usually at tax time, but sometimes all year round. Or you can refer them to a financial advisor. One scenario I'm thinking as an example of when you might do this, sometimes you'll have a consumer come in and they have not filed taxes for 3, 4, 5 years, even if you talked to them last year and told them to. They're going to need more help in that regard than you are able to give them. You cannot offer financial advice, but you can help get them to the resources where they can fix that and start getting advanced premium tax credits, financial help again.
A lot of times people who are considering retiring too need to talk to somebody about what are they going to live on for the next 3 years until they go on Medicare, and are they going to be pulling from any 401ks, or if their income's high, does it make sense to purchase a marketplace plan with a health savings account so that they can put money into that HSA to use for their health care now or even in the future, but will reduce their taxable income.
Right.
So the worst mistake that you can have, I think that I've done this, and it's heartbreaking, is to jump into a marketplace application and not understand completely that somebody might have health insurance offered to them from their employer. And you certainly don't want to show them a zero premium benchmark plan when in fact they have insurance offered to them from McDonald's with an $8,000 out-of-pocket maximum. So we really want to make for sure we're screening for employer coverage. The prices on the marketplace are so good right now, it's easy to get excited about it, but it's something we've really got to take the time to ask about. CMS has a great health coverage or employer coverage tool. Covering Wisconsin has one, I believe, on their website. And sometimes we just plain have to call HR departments. And I do that with my applicants all the time. If they don't understand what's offered to them, or in this scenario in the Healthcare.gov application where people sometimes have a health reimbursement account or the QSERA, those things sometimes you just need to make a call to the HR department and ask for a little help understanding what they're offered.
Yeah, I just want to underline that. That is something you're going to need, that piece of information, and you're going to need to know it exactly. So HR often has a good idea of whether or not it's meeting the standards, and we'll talk about that in a second. But you want that exact number so you can look and make sure that it's affordable or not affordable.
Yeah. All this information is pretty easily viewed on the Marketplace website or Health Reform Beyond the Basics. There's a great link to understand employer coverage and premium tax credit. I did want to point out that the contribution has been updated for 2022. It's now 9.61% of household income. Did you want to make a nod to the family glitch?
I don't, but I have to. But I want to start with the 9.61. Just as a tip, I usually start when I'm explaining this to a consumer. I usually start just by telling them 10%, and if it's closer than that, we will look more closely, because 10% is easier for them to look at. It's easier for you to think about. And then if it's close, and it often is because employers want it to be close, then you start looking more granular at 9.6 and getting that exact number. But yes, the family glitch is not fixed. It's something that for all the new people, if you are offered insurance and the individual insurance is affordable, considered affordable by that test right there. But they also offer family coverage because you have a big family and you need your family covered. Obviously, you need your kids to be able to go to the doctor. You cannot go to the Marketplace and get a tax credit because you are offered an individual plan that is affordable to you. Doesn't make any sense. Absolutely does not. They are not allowing you to cover your whole family. It's just, you could be looking at a $14 premium for health insurance for yourself, and that could be a really not great plan, but it could be $800 to cover the rest of your family, and the Marketplace just does not account for that. It does not give you the tax credit to make up the difference.
We can hope that that gets fixed in this administration.
Yeah.
Before we move on, Adam, give me a reminder. What's our cutoff time today? I forget.
10:15 maybe?
Allison, if that's wrong, you'll jump in, please.
Yeah.
That is wrong. You have until 10:30.
Oh, great. Yeah. Okay, perfect.
And there are a few questions. So if you want to answer those now, we can, or otherwise you can hold and we'll do those a little bit.
What do you think, Adam?
Let's do some questions. This sounds fun.
All right, I will go ahead and read them. So first question, I've recently been receiving a host of calls from consumers that are on the Marketplace plan while receiving unemployment compensation. However, they are now receiving no income and cannot afford the monthly premiums. I've been having the conversation of considering an application for Medicaid Badger Care Plus. Is this the correct method of direction?
In most cases, typically I use that as kind of a benchmark. When somebody's monthly income drops to zero, I'm thinking Badger Care immediately, and you can help them plan for that transition. You can say, okay, this is the last one you can pay. Okay, then we'll pick up right here with Badger Care, and we can do Badger Care application later in that month even, and it'll go back to the first. Because you know that income is going to be zero, you can be very confident that you're going to be able to get them on there.
And let me just say, as a best practice, I would not terminate Marketplace coverage until you have confirmation that you've got active Badger Care.
100%. Yeah. With any coverage, do not end a coverage until you are sure of the transition.
Great. The next one is actually a comment. I highly recommend using the word assistance instead of tax credit. We will eventually tell them about the tax credit when explaining that it will be reconciled when they file taxes.
Yeah, that is a good comment, because the tax part really does throw people for a loop. They don't understand, this is on my taxes. That's what they hear when they hear tax credit. So yes, when you get to that question later in the application about, have you filed taxes? Do you plan to file taxes? That is the time to explain, hey, okay, that number is going to be based on your income, and this is our best guess. And if you are within this range, you will get money back or have to pay in. And I think, Julia, you have a good resource, a table for the limits on paying back tax credits, right?
Yeah, we're going to get to that, but I want to comment that I love that feedback about assistance, and it shows that everybody's thinking about ways to make language clear over the phone.
Yeah, 100%.
Awesome. All right, next one. I've had a few young people receiving student benefits, either grants or student loans. How are those handled for Marketplace and or Medicaid?
Adam, can I take this one?
I was going to say, you do more young people than me.
I work with a lot of young adults. So what I explained is that if you're receiving a scholarship or grant, that's not like a loan that you take out, but a scholarship or a grant, that the Medicaid system will look at your books, fees, and tuition, and any money left over from your grants or scholarships that wasn't spent on books, fees, or tuition, they count as income over the course of your semester. So if you have $5,000 in grants and scholarships over your semester, you only need $4,000 to cover your books, fees, and tuition. That $1,000 that remain is spread out over the course of your 5-month semester and counted as income. All students know how to navigate to their page on their enrollment to print out their, I don't even remember what you call it. What do you call it? Yeah, where it shows your awards.
Awards, yeah, I was gonna say.
Your kind of your encapsulation of your expenses for the
Right.
semester.
Your financial aid.
Exactly, and in fact, they need that to.
Yes,
they
will.
need that to use as an income verification. So our conversation is, go to that information on your website, read off these numbers to me, and then we're going to provide that information when we call and apply for Badger Care for you. And if they're working part-time as well, that gets factored in as well. But housing and food are not considered expenses that are exempt from counting income.
Right. And then between those lines, you want to look for if there's any, especially now, month that didn't have any income. That's important. And you want to check that annual as well for a gap case, because they probably know both semesters. Usually when I work with a student, they have an idea of what their financial aid looks like all year. And they'll come to you if something changes, but that you have some options there.
So we can use this case as a good example for gap filling as well. If they work very minimally through the school year, but in the summer ones, they're working full-time hours. If that full-time hours only adds up to $8,000 throughout the summer, and they work very minimally, it's very possible that they will be under that 100% annual threshold, which is 12,000 something. And if they're applying in a month when they're working more, they might be eligible for Medicaid through that gap filling lens.
Yep.
All right. The next question has to do with family glitch, and there's a little bit of conversation about it too. So family glitch is due to ACA being written when family coverage and single coverage was more in line cost-wise, right?
So,
and then, well, I'll say, so somebody else responded, said possibly, but I believe that it is more because they truly wanted the subsidies to be used when people had no other options. This relates to why if you're eligible for Medicare, Medicaid, or group coverage, you're not eligible for subsidy.
So personally, I have always more agreed with the former. I thought it was an oversight, and I thought it was one that people, it's in the law, and that's why it's so difficult to change. And that I assumed that it was an oversight, and that people, especially insurance companies, of course, family coverage is more expensive. They're in no hurry to fix that. Could be wrong. Like I said, I've always assumed it was an oversight when they were working on the ACA, because it's a lot. It's a lot.
Yeah. And the bottom line is it's still there.
Yeah,
for whatever reason, it's still there.
Yeah, exactly.
All right, and we have one more, and then we can go back to. Well, actually, we have three more. Do you want to keep going, or do you want to go back to your presentation and see if we can come back to some of these?
Let's make for sure we've got enough time. And give more time at the end.
Yeah,
sounds good.
I mean, I love questions. We could stop and do questions. I'd be really happy with that, but we'll keep going. So looking at things that are offered to somebody, you have to also keep in mind things that are not health insurance or that don't meet the minimum standard. One of these, you're going to see fixed indemnity plans or fixed indemnity medical benefit. And that is, first of all, it's awful language. That is some of the worst language to help a consumer that you will hear. That means that's a supplemental insurance, right? And it may like to dress up like regular health insurance, and it may have a statement that looks very much like full health insurance. But at the end of the day, it's going to leave and the person's going to be stuck with the bills.
Can I just say that people don't understand what's offered to them from their employer, and I ask them to actually, drop off a copy or, email me the summary of benefits, and all HR departments are required to provide that information because I need to see it.
Yeah, that's what I was talking about when you were talking about calling HR. You need to see that document, so you need to know what's offered. This one, Julia, came from.
This is from another temp agency, and the name of it looks like it would be health insurance. It comes in the form of a summary of benefits that we're familiar with looking at.
Yep. This looks very much like the summary benefits you're going to see on the marketplace. But you want to look at the details, and sometimes there's some red flags you can look for and identify immediately. This is a problem. This isn't full benefit health insurance. And if you see things like lab tests and regular x-rays, things that are normally covered or at least partially covered with co-insurance, and it says not covered, then you know it's not meeting the standards. If it says emergency room, not covered. It says, pregnancy related services, not covered. Anything like that jumps out at you, and then it's not meeting the standard for minimum essential coverage. And then right here, this is at the end, usually at the end, there's language. Sometimes it's really helpful in an employer plan that does meet minimum value standard because you can look at it, but it's important not to get those mixed up. I was just talking about minimum essential coverage, which is the essential health benefits and making sure it covers all of the things it needs to. Because the requirement to have health insurance says you have to have health insurance that meets that standard, but then also, does it meet the minimum value standard? Is it paying 60% at least of those charges and co-insurance? If it says no, you can figure it out on your own, but if you can skip to the end and it says no, you know that the person doesn't have to take that, and you can go to the marketplace.
Yeah, this was handy once I learned that you could, get an answer to this right away on that back page.
Yep.
Because it's hard to look through other people's health insurance offerings and understand what it's saying.
I enjoy it. I think consumers, I get a kick out of their documents and seeing what's out there, seeing what's offered, and looking at those details.
But you're experienced, Adam, and I think this goes back to the discussion where people indicated that they're less confident about talking about plans. This, to me, nobody ever showed me how to look at health insurance that was offered from somebody else.
Yeah.
And I was not confident in saying, yeah, you can go to the marketplace because this does not meet minimum value standards. Asking for the summary of benefits was very helpful to me.
And the other reason to ask, and the reason to, yes, Julie, you're absolutely right. You're not getting a training on that, really. That's looking at the employer-sponsored coverage. But it is important that you learn to understand it, or you take your time with it, or you get the answers from HR, because that might be the best plan offered to your consumer, and you want to know that as well.
Can I make a nod at this point to say, now I'm telling you that I know more how to look at this. For years, my backup was our agent community in our area. And I'm very lucky that we developed relationships with agents in our area right when the Affordable Care Act rolled out. And we relied on them for years and years. And I still call. I have 3 numbers saved on my phone, and one is to our agent friends in the area. When I have questions about health insurance, plan design, or things that I just don't feel confident in, having relationships with agents in your area and having that list of agents that you can refer consumers to if they need help beyond what you can provide, they've helped me understand for all these years, and I value the relationship with them.
And
you know
you can
who
also,
you are out there.
I was gonna say, and you can also email Julia and me, because that happens, and we're helpful most of the time.
So I want to spend a little bit of time talking about the whole reason that we do our health insurance enrollment is because people need to access care. I work for a community health center, and it took me a long time to feel comfortable talking about people's care needs, but I didn't need to know the difference between chronic and acute, or no diabetes medications when I started this, and you don't either. It's more of a point of listening and understanding how to use the tools that you have available. I take notes when people explain their health conditions. I ask them to spell their medications so that we can look it up in the formulary. I even say, tell me a little bit more about what kind of care you need to access. Do you need to go monthly to get blood tests? Do you need to go quarterly to your psychiatrist to meet and have a med conversation? Because that's going to be a specialty visit. I spend a lot of time talking to people about accessing the free care, the preventive care. I was on the phone with a woman last week, I'm sorry, who hasn't had, she's 64. She hasn't had a mammogram, a colonoscopy, a well woman visit with a pap smear in years. And so enrolling her in coverage in the marketplace, letting her know that all of these things are $0 and that she really needs to call and make these appointments. And I provided her the name of the health system and the doctor system. She hadn't established with primary care. And a lot of the reason people don't do this is they don't understand what it's going to cost, or they've been to the doctor and got bills that they didn't understand, or worse yet, waited until they ended up into the emergency department with huge uncovered bills. So I do spend a lot of time talking with people about accessing care, because for me, the enrollment part is just a means to the end to getting you starting on a health journey that's going to improve for you, keep you insured and maintaining coverage so that you can stay on this healthier path.
Yeah. And the one thing I want to say that you made me think of, Julia, is, when somebody comes in and they say, I do need this monthly, or I need to meet with my psychiatrist. Again, when you're doing that interview and using those interview techniques, it might be the very first piece of information you learn, because it's what made them pick up the phone and call. And I usually find that to be the case. And they want to see this doctor because this is the only doctor that understands this condition to their satisfaction. That's going to really shape how you help them.
Well, and you can use that information that you heard in the beginning to create a scenario. Yep. To wrap that conversation in a real life example of what it might look like if you use care. If you go to the primary care doctor and have a $5 copay, they may ask for that at the desk. If while you're in the office, they need to do some blood work or do any tests, that first money that you spend will reduce your deductible. From then on, you're going to pay a portion of your care until you reach the maximum in your plan year. And I wrap all of those concepts in the story that relates to them and makes sense to them.
Yeah, same. Yeah, they want to see it. They need to see it to feel confident using it.
Okay, so speaking of confidence, here's time for our second poll question. I have a feeling I know where this is going. Do you feel confident talking to consumers about accessing healthcare? We'll give that a couple of
I didn't
seconds.
answer the first one. I didn't know we could answer them.
Oh, I'm really happy to see that.
Right. Yeah, same. Oh man, that's awesome.
So Adam, you and I had a bit of a conversation. I'm steeped into the coverage to care, which, by the way, as a community health center who started the conversation about the Affordable Care Act, when this rolled out in our community, I feel like we coined this before CMS. But do navigators also have conversations about accessing healthcare, like CACs or enrollment assisters in health centers?
So, I like to start with the saying that CACs and navigators can do the same work. They get the same training. And I just want to be really clear about that, because you could be a CAC and know everything I know. But navigators have a requirement with the Navigator grant that we get to go above and beyond with education, and to go above and beyond with outreach, health insurance literacy, making sure people understand their coverage. So you might be, a consumer might just see a CAC at a hospital as part of their process of discharge, or they could find, through 211 or another resource, a navigator, and we're really going to put a lot of time in.
I knew the answer. I just wanted to let you say it.
I was wondering where you were going.
So part of my question, and I don't know where it comes in our conversation, I always ask, where did you hear about us? Because oftentimes we're one of many people that consumers have reached out to try and get answers. And a lot of times it's when they've been released from a hospital or being referred from like a free clinic in the area, and they know they need health insurance to cover an emergency and to cover the work that they have ahead in their health journey. We get a lot of referrals, word of mouth from friends and family. And this tells us about, it's kind of a marker of how we're doing in our outreach in our community. If you're getting referred to me from a navigator, a cancer navigator, which is different than an enrollment navigator, I know that our messaging of providing this health insurance enrollment assistance is reaching your health system. The free clinic has our cards in their desk, and even though they'll provide free primary care, if they need care that they can't access there, or they're referring somebody to specialty care, you need insurance to help cover those extra cares needs that people have. So that this outreach, this to me is an outreach question, and it helps us understand and gauge where we're successful and where we need to continue our outreach efforts.
Yeah. And one other thing, we see a lot of, word of mouth, as Julia mentioned, friends or family. I just want to say that if it's friend or family, it's usually because that person said, this person solved my problem, you need to go see them. And that gives you a huge leg up in starting a conversation and having a good rapport and that trust we were talking about. So, don't always put in all the effort you can, because people are going to spread the word. And that's really what we need. We need people to find the assistance, to get the coverage, to get the care.
A lot of referrals from the Aging and Disability Resource Center, other community partners, shelters, food pantries. We've been working integrally with an effort to vaccinate people in our community, and all of those efforts, even though they might be around healthcare or vaccines, loop back into health insurance enrollment. We've really tried to embed health insurance enrollment into the community.
It looks like questions are kind of piling up, so let's get through this one especially.
Yep, and anybody who knows me knows that there's always got to be a cat in my presentations. So what I'm really hoping, and our conversation, I think, will show that we've provided you some listening techniques, some examples of language, and thank you to people who are listening for contributing your simplified language. Help us make a clear path of enrollment, and really the main goal is to help people get connected to care. Before we go to questions, I want to point out a couple of resources that I use. Adam, I don't know how you get by without using these resources. You must have it all in your head.
Don't tell people that. Do not tell people that.
Adam's got it all in his head. I need to look at things, and it also helps me to remind people to have the conversations. For instance, this is the Health Reform Beyond the Basics yearly guidelines and thresholds. It's just been updated for the 2022 enrollment year. It's really important for me to understand in this top box where the silver plan cost sharing breakouts are. If you have an income that's $50, that might kick you into paying a whole lot more out of pocket costs. Remember, this is an income estimate. And if we're estimating and by putting in a number that might kick you into a much higher cost sharing, we might estimate that you're not sure that you're going to make that extra $50, because I want you to be in affordable coverage and access care, within, non-fraudulent activities, but really be mindful of where that cost sharing falls. And I also really love the repayment limits of tax credits.
Yes.
Because again, if you underestimated your income a little bit, you might benefit from knowing your repayment will be limited.
It makes consumers feel a lot better when they're thinking about, hey, I really don't want to get this wrong. If you can show them the limit on what they might have to pay back on their taxes, and that usually puts people's mind at ease.
Exactly.
We have a lot of sheets. I think this will probably be in a bunch of CWI presentations covering Wisconsin. So I will say we have a lot of sheets on our website. Some of the most useful ones I find are what's free. Julia mentioned this. It's important for people to know, hey, now that you have coverage, you can do certain things that don't cost you anything, and you probably should. So with preventive care, but we also have affordability worksheets and a lot of things on the different coverage for immigrant populations. There's just a ton of sheets on our website that are worth using. Go through it, find the ones that work for you in an appointment, and have those handy, just like the other tools.
It helps provide you with simplified language too, because these have all been vetted with consumers. So if you're having a hard time explaining to somebody, reading this and getting the language from these materials helps you explain. If you're stumbling, I would look on the website and look at all the offerings of how-to sheets to help you do your job better.
Yeah, and that stumbling comment made me think, if you're using a sheet or a resource or something and you find you're consistently tripping over part of it, or it's not easy to explain from that language, let us know. We want to know that. So yeah.
So you will have noticed that we did not do a walkthrough of the Healthcare.gov application. By the time you get to the application, it's fairly straightforward. There are some tips and tricks for different scenarios. Other organizations have done that really, really well. The Health Reform Beyond the Basics webinar series is fantastic. I hope you go back and get a chance to watch all of these if you missed some of them earlier, and there are more to come. Even the CMS training, the advanced assister tips, I think, shows a lot of screenshots and scenarios of the Healthcare.gov application, but we really felt like this was a good way to get you started on your enrollment path.
And one way to get more comfortable in that, Julia, I found is to create a marketplace application for myself and just not submit it, but it lets me play around and see if there are new questions each year, just to get a feel for it, and that could make you more comfortable with the application itself.
You know, I'm constantly getting reminders because I was on the marketplace in 2014 for a couple of months. And every year I log in and go through it and just to see what it looks like, because it gets updated. I don't pick a plan, I get reminders to pick a plan. So I have submitted applications from every year since 2014 that just sit there.
Yeah, that reminds me. That one walkthrough we did, I still get notices from that, by the way.
Okay, one last thing before we answer questions is you're going to be following up with a part 2, but you and I were talking about how do we do previews with consumers before I even do an application. I will preview plans and prices with them so they can kind of calm down and understand what the prices are and be more assured that it's going to be affordable. The way to get there, it's really hard to find it. And you said you do some ridiculous Google search. If you just go to healthcare.gov and type in preview in the search bar, it will bring you to the preview tool.
Yeah, my methods that make sense for me don't make sense. I think maybe we should we got 5 minutes left, to the questions, because it sounds like there's some good ones. And I just want to remind people, Julia and I are doing an office hours open discussion on Friday morning. So we will be back if we don't get to all the questions.
Right. Yep. I was just going to say the same. All right. Let's see how many we can get through. First, I had a consumer that was offered insurance through work. Husband was self-employed. When figuring the affordability was very close. We figured out if the wife took the insurance through work, which lowered her taxable income, the rest of the family was able to get on the marketplace because the taxable income went below the affordability percentage. Make sure to look at all options. So that was more of a comment.
Yeah, I see what you're saying, though. Yeah, you could do the affordability test, find out that they would be eligible for tax credit and still like that employer coverage for that one person. Yes, that is something that can happen.
So let me just say that if it's close or I'm not quite sure, I will put the information in the healthcare.gov application and let the marketplace do the determination. Because if they determine you're eligible, that's the word.
Yep, exactly.
All right, next one. Referring to the spouse and family that will cost so much more, your $14 for primary and $800 for family example. What if the spouse is the primary applicant for marketplace? Their insurance would be $800, which would put them as not affordable. instead of having primary insurance holder as the main marketplace applicant. Just a thought.
Julia, does that work? I don't think that works.
I don't know that I understand the question. Maybe we can work on that and do it for office hours.
Yeah, we can definitely take that back. I'm really curious about that one. Thanks.
All right, next one. Are HSAs from employer considered an acceptable work insurance?
Acceptable in terms of meeting the standard for insurance? By themselves, no. The health savings account is not just meet the standard, but health savings account can help you lower your taxable income to make sure you're eligible, fall under other thresholds for coverage. Anything else on that, Julia?
No, let's save that for office hours as well.
Okay.
And then I think the rest of these are comments. I will read them. One is co-pays will count towards the maximum out of pocket, not the deductible. The deductible, co-pays, and co-insurance all count towards the maximum out of pocket.
Yes, that's true. And if I misspoke while I was giving examples, that's absolutely right. So it is good to have your head wrapped around how it really works when you're explaining it.
Mm-hmm.
And here's a really critical comment. Julia and Adam are absolutely amazing resources, and I'm so grateful for both of you for being so accessible. Thank you.
Well, thanks for your feedback.
Yeah, that's really nice. Thank you.
We geek out over this work, honestly.
Yeah.
What I didn't say in our introductions is I was a hobby farmer until I was 47. I didn't have a career in health insurance. I raised chickens and goats and pigs and dogs. And who would ever think that I'd love working with consumers? And again, it's the intricacies of the enrollment work, but people are trying to get healthy, or people have experienced some catastrophic health issue. And oftentimes, and I know this because we get the feedback, just like Bridget, who was working with Ron, his comment to her was, "You're an angel on earth." And it's so satisfying to help people understand finally health insurance and start getting care. So thank you.
That's what you're in it for.
Yeah.
There is one comment, I'm not sure if I fully understand it. It just says preview. I put in, quote, see plans.
Yes. I mean, when you use the preview tool, yes, you want to see the plans because you type in the zip code and get the rough estimate. Yeah, that is how that works. Oh, you mean for the search. So instead of searching preview, you can also search see plans. Oh, that's a really good tip. Yeah.
Yeah. It's a good marker.
So that's all we have in a Q&A.
Looks like there's one in the chat, which I just opened. It says, can we enroll in Marketplace and Wisconsin Well Woman program? Yes, the Well Woman program is different than Well Woman Medicaid. The Well Woman program is not full insurance. It covers a number of different services for women, women with breast cancer especially. I think Well Woman coordinators can answer all your questions about that. But yes, because it's not full insurance, you can also have Marketplace coverage.
And we're going to cover that in the advanced Medicaid topics on Wednesday.
Awesome. Fantastic.
There might be one more here. Not sure if okay. Question is, are copays applied to deductibles? There are plans that have copays for primary and specialist care visits instead of paying a percentage of deductible. How do you know if copays go towards deductible or not?
So my answer for that is usually, but yes, that is fine language that's in the summary of benefits. But yes, usually, and we can go into more detail at those office hours. Sounds like half of that session's already claimed, Julia.
Yeah, but somebody just said that the copays reduce your out-of-pocket costs, not your deductibles.
Not
and I believe
always.
That's true.
Yeah. So yeah, there's different scenarios, and then also you could have a separate deductible for medication. Yes, there's always.
This is going to come up, Adam, probably in your session too with Dave, because they're introducing plans now that have no deductible, and there's a copay for everything. So I think we're all going to learn more about this. And again, this is why you all need to have agent friends.
Yeah, that's part 2. That's coming up tomorrow with Dave Chandrasekaran. And yes, I did point those out to him, so I know he's going to talk about them.
I see that we are at time. Thank you again so much, Adam and Julia. Such a wealth of information. Really, really great tips and tricks, as the session title indicated, right on the money. And I do hope that those who in the poll indicated that they could use more practice, I think it comes with just doing the practice. So I think that's right on as well. We're all still learning, even Adam and Julia, as you indicated. Yeah. So thank you. We're going to take a 15-minute break. We will come back here at 10:45. As always, you can just keep this link open and we will see you then. Thanks.
All right. Thanks so much, guys. Great questions.
Well, welcome back. We are just after 10:45, so we're going to go ahead and get started. And I believe, Stephanie, are you moderating this session? Is that right?
Yes, I am.
There you are. So you were here last week, which I know many of you were. You're familiar with Stephanie Sievers, our Health Literacy and Communications Manager for covering Wisconsin. So this session is really, well, I'll let Stephanie take it over and introduce the session. And thank you all for being here.
Yeah, great. Thank you, Allison. Thank you everyone for joining us. Today's session will be largely Medicare basics with some additional information that's often important for enrollment assisters to be aware of or to know or to pass on to consumers. I do have one speaker who hasn't quite joined us. She's at the end, so fingers crossed she'll be able to log on. I know I had some technical difficulties with Zoom this morning. So, and then I believe, Tiffany, you're gonna share the slide deck. Great, and I'll just talk during the first couple of slides and hand it over to Tiffany. Okay, so Medicare basics for enrollment assisters. Go ahead and advance. Okay, so here are our speakers today. We have Kate Schilling, who's the Legal Services Manager from the Greater Wisconsin Agency on Aging Resources, otherwise known as GWAR, which is a lot easier to pronounce. We have Tiffany Scully, who's an Elder Benefit Specialist from the Area Agency on Aging of Dane County. Vicki Buchholz, Medigap Helpline Supervisor, Services Supervisor. I'm trying to talk too fast, I think, from the Wisconsin Board on Aging and Long-Term Care. And Abigail Musselman, she's an information and I forget what the A stands for. Assistance, maybe, specialist with the Aging and Disability Resource Center of Dane County, otherwise known as the ADRC. So we have a lot of expertise and knowledge in this panel, and I'm really excited for them to start talking. I've got to say it's a full slide deck. We're trying to break it up and make it easy to understand, but I want everyone to remember Medicare is hard. You thought Medicaid and Marketplace were hard. Well, Medicare is a beast, a whole different type of beast. So let's go easy on ourselves and make sure we know we don't have to be experts in this. We need a few basics, and we also need to know who are our experts where we can refer our consumers. So here's the agenda. First, there's going to be a brief description of the Elder Benefit Specialist Program. And then a brief overview of Medicare basics. And then we'll talk about Medicare subsidies, which starts getting into the really complicated side of Medicare. And then transitioning from Marketplace to Medicare coverage. And there are some special considerations that we all need to be aware of. And then lastly, we'll talk about the Aging and Disability Resource Center and how it's going to be in our back pocket to make sure we can get people the coverage that they need and to transition in the right time. All right, and let's start with a poll question. Where do you refer consumers today who need enrollment assistance or detailed help with Medicare? We've got A, agents and brokers, B, Medigap helpline, C, my local ADRC, or D, other, I don't know. There we go. Okay, 21% agents and brokers, 6% Medigap helpline, 62% my local ADRC, and 11% other, or I don't know, or maybe non-applicable. So great, that's very helpful. Thank you, everyone. All right, I think the next slide, we will hand it over to Tiffany.
Thank you, Stephanie. And I apologize. I keep advancing the slides, but I don't know if my keyboard is sticking or what. So hopefully it won't be too rough as I continue on. Thank you, everyone, for attending this presentation and for having us. My name is Tiffany Scully, as Stephanie had mentioned. I'm one of the elder benefits specialists in the state of Wisconsin. I work for Dane County in the Area Agency on Aging. I thought it would be helpful if first we gave a little brief overview of our program, and I'm going to talk about our program, and Vicky's going to discuss her agency, and Abigail will talk about ADRC. So along with giving you information on, what is Medicare and what are programs that can help people save money, we're also educating you on resources that you can then pass along to the consumers that you're working with. For some reason, it is just not advancing. So all right, here we go. So the purpose of the Elder Benefits Specialist Program is to provide broad access to public benefits and legal rights. So we're a legal services and advocacy program in the state of Wisconsin. There's at least one elder benefit specialist serving every county and every tribe in the state. The program dates back to sometime in the 1970s. The funding for our program comes through the Older Americans Act. So that's the federal funding. There is state funding and local funding. Like I said, the amounts do vary by county. Some counties have more than one EBS. So here in Dane County, we have 3, and other smaller counties might just have one EBS, which is kind of more typical for especially the rural areas in the state. All elder benefit specialists, and I'm just going to refer to us as EBS, are state health insurance program counselors or SHIP counselors. We are able to contact Medicare based on having that SHIP designee. So if I'm assisting one of my clients with a Medicare appeal and I need information on claims that were processed or when their Medicare, what drug plan they're enrolled in or whatever, I'm able to contact Medicare directly without the beneficiary to get some of that information. We receive ongoing legal training from GWAR, the agency that Kate Schilling works for. So Kate is one of the program attorneys. She's the legal services manager at GWAR. So she supervises a number of elder benefit specialists throughout the state. So her and the attorneys that she works with provide at least quarterly training to us on these various programs, public and private benefits, including Medicare, Medicaid, Social Security, SSI, food share, et cetera. This next slide just talks about some of the areas or some of the things that we help our clients with. So Medicare appeals are a big one. If a consumer has Medicare and they have received their Medicare summary notice showing that they've had a claim submitted by their medical provider that was denied, we can look at whether there's merit to assisting them with an appeal of that decision if we think that coverage should have been extended for that service. We assist people with Medicare enrollment issues, coordination of benefits, Social Security overpayments, Marketplace and Medicare overlap and appeals, Medicaid appeals. So there's as you can see, there's a great depth to what we can do. It's important to note that the referral process can be different for every county. So it's best to refer consumers to the ADRC, the Aging and Disability Resource Center that serves their area, because then an information and assistance specialist like Abigail can walk them through the process of getting a referral to the EBS program. Or if the person is under age 60, there are disability benefit specialists who can work with that population from 18 to 59. It's important to note that with the Elder Benefit Specialist program, the person who's having the issue or problem is the one that needs to reach out for the referral to request assistance, or a power of attorney for finance, agent, or guardian of estate. We can't accept referrals from, someone's neighbor calls and says, my my neighbor has a problem with Medicare. Could you please call her? Unfortunately, we're not able to make a cold call like that. So it really does need to be the person or their legal representative. Before I move on, are there any questions, Stephanie, before I get into the Medicare basics?
No, I think we can keep moving along.
Okay. I'm going to pause, and we'll all pause periodically for questions, but we just ask that you try to keep them basic, because if we get into too many detailed or complicated, kind of more personalized scenarios, we just unfortunately don't have enough time to cover all that. We have a lot to go through. So I'm not sure how familiar everyone is with Medicare, but just to go through the very basics, it's a national social health insurance program that started under, or was added to Title 18 of the Social Security Act in 1965, at a time when a large portion of older adults could not afford insurance. Today, the people who are eligible for Medicare are those lawfully present residents or US citizens who are age 65 or older, or under age 65 who have certain disabilities and have been receiving Social Security disability benefits for 24 months, or people of any age who have end-stage renal disease, which ESRD is the acronym we use for that, or Lou Gehrig's disease, which is known as ALS. There are 4 parts to Medicare. Part A is inpatient coverage or hospital insurance. So that is going to be claims for hospital stays, skilled nursing facility stays after a qualifying hospitalization, hospice services, some home health care, blood. Part B is outpatient or medical insurance, and that covers doctor's services, outpatient surgery, outpatient therapy like physical therapy, occupational therapy, some preventive services, so like a mammogram. Medicare Part C is Medicare Advantage, and I do have some slides on Medicare Advantage coming up. Part C is an alternative to having original Medicare A and B. So these are private companies that are contracted with Medicare to provide all the services and benefits that people who have A and B could get or are eligible for. And they can charge different amounts for those services. So like I said, we'll get into that in a little more depth in just a bit. And then Medicare Part D is prescription drug coverage. And that part was just added to Medicare around 2006. And those are also private companies and plans that are approved by Medicare to provide that coverage. And those contracts are established on an annual basis. So who runs Medicare? Social Security is actually the agency who enrolls people and assesses their eligibility and collects the premium payments for Medicare, whereas the Centers for Medicare and Medicaid Services, known as CMS, actually administers the benefits. And then if someone is a retiree of the railroad actually will enroll those individuals. So there's a couple different scenarios with enrollment. If you're working with someone who's already collecting, say, early retirement benefits from Social Security, because like I said, people who are 65 or older are eligible for Medicare. However, some people start collecting early retirement benefits through Social Security beginning at age 62. So if those people, or if they're getting disability benefits, then those individuals are automatically enrolled into Medicare A and B by Social Security, and they'll receive their card, as you can see an example of it on this slide. They'll receive that prior to their 65th birthday or their 24 month of receiving disability benefits. However, if someone is not receiving benefits actively from Social Security, they're going to have to initiate their own enrollment by calling Social Security, doing it online, calling the national number, which is the one listed here. I can say that I've helped many people apply through the website, and it is a fairly simple, straightforward process, and it really doesn't take that long. Whereas if you call the Social Security office for an appointment, they could be booking out weeks, if not months. So I just wanted to give you that note. It's really important that people understand when their initial enrollment period is for Medicare. For those people who are turning 65, it's a 7-month window that starts 3 months prior to their 65th birthday, includes the month of their 65th birthday, and then the 3 months following that 65th birthday. So that is the period of time that people have to sign up. And depending on what month they do enroll, that is going to impact the effective date of their coverage, especially, well, particularly under Part B, because if they have Medicare Part A premium free, if they've worked and earned 40 quarters of coverage through payroll taxes over their lifetime, then they'll have premium free Part A, and that can be backdated up to 6 months. However, the Part B won't. So if they wait 3 months after they turn 65, then their Medicare Part B will be delayed. The only time when someone should delay enrollment in Medicare A and B is if they or their spouse are actively employed and have group health plan coverage through that employer. Then they can sign up within 8 months. They can sign up anytime they have the coverage, and then up to 8 months following the month either the employer group health plan ended or the employment ended, whichever occurs first. And in that case, there's no premium penalty as long as they sign up during that special enrollment period, and they'll have to provide proof from the employer that they had that employer group health plan, and Social Security has a specific form for that. Otherwise, they should enroll during their initial enrollment period. And Kate does have a slide later on that does touch on Medicare and employer insurance, because even if the consumer does have an employer group health plan, they might still want to sign up for Medicare depending on how many employees that employer has, because that impacts the coordination of benefits between Medicare and the employer group health plan. If you're working with someone who missed their initial enrollment period and they don't qualify for a special enrollment period, then the only time that someone can sign up for Medicare A and B is during the annual, it's called the general enrollment period. And that runs from January 1st to March 31st. So anytime during that 3-month window, if someone contacts Social Security to enroll, their coverage will not begin until July 1st. And eventually that's going to be going away in 2023. But so this next upcoming general enrollment period that goes from January 1st to March 31st of 2022, anyone who signs up during that period of time, their coverage will start July 1st of 2022. And it's possible, depending on how long they chose to delay their enrollment, they could have some premium penalties. And that's listed here in red. So there's a 10% increase in the Part B premium for each full 12-month period the person delayed enrolling. And that lasts for the rest of their life. So if someone went 20 months without enrolling, they'll have a 10% increase in their premium because they only went one full 12-month period. As I said, some people don't pay any premium for Medicare Part A if they've had enough work credits based on paying payroll taxes. However, if they do owe a premium for Part A, if their work history is not sufficient, they'll also get a 10% increase in that premium amount for each full 12-month period they delayed for twice the number of years they went without coverage. So eventually that penalty will go away. But still, Medicare Part A can be really expensive. And so having an additional increase to that premium can be very challenging for people. Are there any questions, Stephanie, before I move on to discussing original Medicare versus Medicare Advantage?
Yeah, there are.
Okay.
So let's see, why would a consumer not enrolled automatically in Medicare on or about 64 and a half, other than a consumer not worked enough years? I don't know if I read that right. So
Okay, let me just look at that.
why would a consumer not be automatically enrolled in Medicare? Maybe that's the question.
The only people who are automatically enrolled are those who are already collecting Social Security benefits, either disability or retirement. So if a person's not collecting any benefits, then they have to initiate that enrollment on their own. And if they haven't worked enough years, anyone can purchase Part B, the outpatient coverage. If they haven't worked enough years to qualify for premium-free Part A, then they can get Part A. They just have to pay a premium for it. And it depends, the amount of the premium will depend on how many work credits are on their Social Security record. And Social Security can give a person that information. So a consumer could just call Social Security and say, how many work credits do I have on my work record? But the premium, depending if people only have a few work quarters, can be over $400 a month.
Okay. And then could you please talk a little bit more about what will happen in 2023?
I don't think that, the only thing that I mentioned with 2023 is that people will no longer have to wait until July 1st if they sign up for coverage during the general enrollment period. It's going to switch so that coverage starts the first day of the following month. So if I am enrolling during the general enrollment period in 2023 and I enroll January 1st, then my Medicare would start February 1st, 2023, rather than July 1st of 2023. So it'll eliminate that long gap where people are waiting.
Mm-hmm. And then there's a question about employer coverage for Part A and B. I think maybe we'll just wait on that.
Yeah, I think Kate will be,
Mm-hmm.
she has a slide on that.
Oh, there is one more that's related to timing here. Oh, I guess there's a few more. If someone is 65 years old and still working full-time, are they supposed to enroll as they turn 65? Or can they enroll after they retire? Okay, that's another work-based.
Okay,
one.
I think we're gonna
let's keep
talk
going
about all of those. Yeah, just in just a little bit. Okay. So this chart just kind of shows you kind of the roadmap that people will want to consider if they want to go for option 1 or option 2 when they first become eligible for Medicare. So option 1 on the left is what we refer to as original Medicare. And so that's signing up for Part A or Part B, which you have to do in either case, option 1 or option 2. If you need to enroll in Medicare, you would enroll in parts A and B. And then under option 1, some folks decide that they want to enroll in a Medicare supplement policy, which is also referred to as Medigap. And I have slide I'm starting to talk about that on the next slide. Or some people have a retiree health plan through their former employer. So that might supplement the costs of Part A and Part B, because I guess I should have started off by saying that Medicare Part A and Part B was never designed to cover 100% of the costs of medical services. There are deductibles and co-insurance costs associated with parts A and B. So we would encourage people to explore an option of either doing a Medigap plan or signing up for a Medicare Advantage plan. If you sign up and go option 1 and enroll in a supplement or have a retiree health plan, that is probably not going to include drug coverage. The supplement definitely won't. So then people would want to look at options for a Medicare Part D prescription drug plan, or they might enroll in Wisconsin Senior Care, which is a state pharmaceutical assistance program that we have here, which is creditable coverage to Medicare Part D. Or they might have access to another form of drug coverage, either through the VA, or maybe it's included with their retiree health plan. Option 2 is Medicare Advantage. So like I said, you have to be enrolled in A and B. And then you would enroll in the Part C plan. And I do have slides on this coming up. So these are private plans approved by Medicare to, again, provide the benefits and services someone would get under A and B. A lot of Advantage plans include Part D prescription drug coverage. Some of them don't. Some people get an Advantage plan that doesn't have drug coverage because maybe they don't take any drugs and they enroll in the Wisconsin Senior Care Program just to have a creditable drug coverage in place so they don't get penalized later. Or they might have other creditable coverage, again, like the VA or something like that. So essentially with original Medicare, and actually I'll just go to my next slide. Medicare supplements are private insurance plans. They're regulated largely by the state of Wisconsin, the Office of the Commissioner of Insurance. You have to have Medicare A and B, be actively enrolled to purchase a Medigap plan, because that Medigap plan is going to cover some of the costs that A and B do not cover. Medicare A and B would always pay primary, and then if Medicare approves that service and says, yes, this is something that we cover, this was medically necessary, Medicare makes their payment, and then they automatically shift that over to the supplement company to process. Premiums depend on a number of factors. If someone's male or female, their age at the time they apply, if they, what kind of plan they enroll in. Again, Medigap plans do not include prescription drug coverage. And there's no need to review the Medigap coverage annually. It's always going to stay the same. It's a contract between the individual and the insurance plan. The costs could go up based on inflation and based on attained age, but the coverage is always going to stay the same. It's important to note as a distinction, someone who signs up for a Medigap plan can see any provider in the country that accepts Medicare. Whereas with a Medicare Advantage plan, a lot of those, and that's on my next slide, a lot of those require people to see providers in a network. So many Advantage plans are HMOs. So it might be more similar to what people are used to with an employer group health plan, where they're going to have the lowest out-of-pocket costs if they see a network provider. Some plans allow people to see out-of-network providers, but with higher costs. Some plans don't cover out-of-network providers, except in emergency situations. So with a Medicare Advantage plan, it's important that if people are looking at that option, that they make sure that the providers they see on a regular basis are included in that plan's network. When someone selects Medicare Advantage, like I said, with a Medigap, a person can see any doctor that accepts Medicare. With the Medicare Advantage, the federal government is paying that Advantage plan a lump sum, from my understanding, for every person, Medicare beneficiary who's enrolled. And then that insurance plan is the one that processes the claims and pays the providers. So this is just kind of a side-by-side comparison. So all of this information is, I already discussed it, but you can just look at it here. With the Medicare Advantage plans, they can change from year to year. So the premium could go up or down. They always have to cover all the benefits and services someone would be eligible for under original Medicare, but they can, again, charge different amounts for it. So it's important if someone does decide to get an Advantage plan that they review their plan coverage and options from year to year. And I'll talk about those enrollment periods in just a few minutes. Here are some resources that you can direct consumers to for comparing Medigap and Medicare Advantage plans. So we have the Medigap Helpline, which is Vicki's agency, and she'll talk more about what they do. Then there's the office, the Wisconsin Office of the Commissioner of Insurance. And if you go to their website, they have a list of approved supplement companies. So all the contact information will be on there, and people can, we just advise consumers to call various companies and get price quotes and compare them. And then Medicare, their website does have a Medigap plan comparison tool. Are there any questions, Stephanie, before I move on to Part D?
There are.
Talking longer than I.
Yeah, well, we have to move along, so I'll just cover a couple of these. There were several questions about how many work credits does a person need to not have to pay for Medicare?
40. So you can earn up to 4 work credits or work quarters of coverage per year. They're based on your earnings, and I don't have the exact quote now right in front of me, but I think this year it's like it's about $1,500 in earnings. For every $1,500 approximately, you would get 1 quarter of coverage. However, you're only allowed to get up to 4 per year. So we say generally, if you've worked 10 years in your lifetime, you probably have gotten the 40 quarters of coverage. But like I said, Social Security can provide an exact number.
Great. And we'll hold on the rest of the questions
Okay.
after Kate talks.
All right, so we're moving on to Medicare Part D, which is the prescription drug coverage. It's important to note that it does not cover any over-the-counter medications. It's only FDA-approved prescription drugs. Again, Part D, these are private plans that provide the prescription drug coverage. You can either get it through a standalone Part D plan or a Medicare Advantage plan that has a prescription drug plan. So we call that MAPDs. The Medigap helpline has a specific prescription drug helpline, and the phone number is here. So they can assist consumers with reviewing their options, because every plan, plans cover the same types of drugs, same categories of drugs, but they don't. Each plan has their own formulary or list of covered drugs, and each plan has their own preferred drugs, preferred brand names, preferred generics. So it is really individualized in terms of selecting a Part D plan. It's all based on what medications that person takes. And I think this year there's about 28 or 29 Part D plans, and it changes from year to year. There are late enrollment penalties associated with Medicare Part D, just like Parts A and B. So if someone wants to enroll in a Part D plan, if they didn't have what's termed creditable coverage, which is coverage that's considered as good or better than standard Medicare plan, if they didn't have that in place and they've gone more than 63 days without having creditable coverage, then they're going to be penalized. And that penalty is under bullet point number 2. So it's a 1% increase in the national base monthly premium, so $33.06 this year. And that changes from year to year for every month that the person delayed enrollment. So I'm working with an individual right now who they assessed a penalty of $54 a month because he went for a very long time without drug coverage. So that amount is then added onto the base premium for his plan. So a $29 plan became, a $70+ a month plan. And here's a list of some types of creditable coverage: VA, senior care. Most employer insurance has creditable drug coverage. And so the employer group health plan will give an individual a notice that talks about whether or not their drug coverage is creditable to Medicare. All right, this is my last slide. Just an overview of the Medicare Part C and Part D enrollment periods. So that initial enrollment period, the IEP, the 7 months surrounding an individual's 65th birthday or 24 month of receiving disability payments, people can enroll in an Advantage plan or Medicare. Well, sorry, let me back up. Yes, people can enroll into an Advantage plan or a Part D drug plan during that initial enrollment period. Then there's the annual enrollment period, which we are approaching next month. So between October 15th and December 7th each year, that's a time where people can enroll in an Advantage plan or a Part D plan for the first time, or they can look at switching their plans or dropping their coverage. Any changes that are made during this annual open enrollment period become effective as of January 1st, 2022. Then there's the Medicare Advantage open enrollment period, which is January 1st through March 31st. So that overlaps with that general enrollment period for A and B. Any changes that occur during that enrollment period become effective the first day of the following month. So that's an opportunity for people to either switch their Advantage plan or drop it. They can't enroll into a plan for the first time during this Medicare Advantage open enrollment period. They can only do that during the annual open enrollment period. And then there are special enrollment periods, which we call SEPs. So there are special specific circumstances in which if people qualify, they can switch their Advantage plan or their drug plan. So for instance, if someone's in a skilled nursing facility, they would have a special enrollment period. Or if someone moves from one area to another and their plan no longer serves their new area, they would have a special enrollment period. So any changes that are made under a special enrollment period become effective the first day of the following month. Stephanie, are there any other questions before we turn it over?
No new questions. And,
Okay.
Kate can address the work require or the employment questions.
All right, great. Thank you very much. That was a great intro from Tiffany talking about Medicare. And I think what's really most important that you take from her presentation is there's a lot to know. So you need to know where to refer people and when to refer people. And just like she said, and will be said at the end again, please refer people to the ADRC. My organization works with ADRCs, but we don't accept any referrals directly. So please don't refer people to GWAR. Please refer them to the ADRCs. Now we can talk about the Medicare subsidies fairly quickly because I know a lot of you have questions about employer coverage. So just like there are marketplace subsidies, we also have Medicare subsidies. And generally speaking, these subsidies are based on income and asset levels. And so depending on a person's income, they'll qualify for certain subsidies. Now there are various subsidies that do different things. So just like Marketplace has premium assistance subsidies, they also have some cost sharing subsidies. Basically, Medicare has that too. So we'll go through those. We'll go to the next slide, Tiffany. So we have lots of acronyms: QIMBY, SLIMBY, SLIMBY Plus, and QDWI. Now, these are called Medicare savings programs. And anyone who's eligible for one of these Medicare savings programs on your screen automatically qualifies for extra help or low income subsidy, which is the Part D drug subsidy. So QIMBY is the very, for the people with lowest income. So it's 100% of the FPL or less, depending on your household size. And this is going to be paying not just it's going to pay your Part B premium, a Part A premium if you have one. 99% of people do not have a Part A premium because, as Tiffany said, they get those for free. They get Part A for free because they've worked and paid into the system for 10 years or more. And then the asset limit. Now, remember with asset limits here, your house, your car doesn't count, your burial doesn't count if it's set up right. So we're talking about cash, a second home or property, CDs, stocks, bonds, things like that. Bank account, checking account. But your house and a car are exempt assets if you have one of each. Okay. SLIMBY is going to pay just your Part B. SLIMBY and SLIMBY Plus pay just your Part B premium, whereas QIMBY, the one I just talked about a minute ago, also pays your co-pays and deductibles and co-insurance for Medicare. And so folks who have QIMBY, it's going to be pretty similar to having Medicaid, but not exactly the same. But you're going to have very low co-pays, $3 at the doctor. SLIMBY and SLIMBY Plus are only going to pay your Part B premium, which is about $150 a month. So that's a great savings. And remember, it also gets someone the Part D subsidy as well. All right. And Part D, we call this extra help or low income subsidy. Different states call it different things. It's actually overseen by the Social Security Administration, which I think is ironic because they don't help people with Part D plans at all, but they do oversee the low income subsidy program. So if someone doesn't automatically get a Part D subsidy, they apply through Social Security, which again, I think is ironic. So there's a full subsidy and a partial subsidy, and that depends again on your income and asset limits. and it also depends on, and that eligibility will determine how much of a subsidy the person gets. So if they have full subsidy, they pay nothing for their monthly premium for a Part D drug plan, as long as they choose one of the CMS designated plans. So there are a lot of rules with this, but generally speaking, for the lower income folks, as long as they have assets within the range, we can get them on subsidies that are going to greatly reduce the costs for out-of-pocket expenses related to Medicare. Thank you. I can move along. Thank you. So it's really important too that people understand Part D did have a coverage gap or a donut hole, as you've probably heard. In 2020, that closed up because of the Affordable Care Act, but we still refer to it because it's still, I call it like a moment in time. It's still a gap. It's still it still determines the price someone will pay during a certain period of drug coverage. So it's essentially closed up for purposes of the open coverage. Prior to the Affordable Care Act, there was no coverage in the donut hole, and now it's about 25%. So we still refer to it sometimes as the coverage gap, but people who have subsidies don't even have to pay the 25% because this is going to close up some of those out-of-pocket costs for them. All right. Yep, we can keep moving on. Yep. Yep. Okay. So Medicare and employer coverage. I think this is a really important topic. A lot of you have had questions on it, and I want to address some of these questions. I'm not going to be able to address them all, but that's why we can refer people to the ADRCs. Okay. So this is the one a lot of you were asking about. When you turn 65, if you're not taking Social Security benefits, your enrollment in Medicare is not automatic, as Tiffany said. So you would have to affirmatively opt into Medicare in order to get it. Now, we get asked all the time, when can I turn down Medicare? And basically the answer is, you have to be working. That's the only reason. You have to be working, you or a spouse. So here's my test. And are you or your spouse actively working and getting health insurance through that active employment? Okay, so you or a legally married spouse. Does your employer have more than 20 employees? And do you not have end-stage renal disease? End-stage renal disease is a beast. It's its own thing. We have to look at those cases individually every time. And I want to say here I'm talking about someone aging into Medicare because they turn 65. The rules actually are slightly different for someone who has SSDI Medicare. If they are still working, their employer has to have 100 or more employees in order for them to not take Medicare when they become eligible. And unfortunately, if they don't, the employer can pay as if they did, even if they didn't, and they will have huge out-of-pocket costs, and you can't get retroactive Medicare. So they are going to have significant out-of-pocket costs. And unfortunately, if someone didn't enroll in Medicare when they should have or needed to, and they have out-of-pocket costs, I will usually have to refer them to a bankruptcy attorney. We've had many clients who've had $100,000, $300,000 looking for, of employer costs that their employer insurance paid. And then all of a sudden the employer insurance 3 years later withdrew coverage, realizing it was actually should have been a secondary payer. And the person should have enrolled in Medicare and they didn't. So it's really important that we are consulting people and counseling them correctly. So that's why these issues have to go to an ADRC, or they need to talk with Social Security directly. Social Security can also counsel on whether or not someone should take Medicare when they are on employer coverage. And so again, it's 20 employees if you are aging into Medicare at age 65. But if you have SSDI, Social Security Disability, and you become eligible for Medicare and you're working, then the test is, does your employer have 100 employees or less? So it does make a difference. So I do encourage people to really be very careful about the information that's given here. Now, as I said, 99% of the people are going to get Medicare Part A for free. because they've worked for at least 10 years or their spouse has. So if that's the case, I say enroll in Medicare Part A because it's free hospital coverage. Great. It's inpatient coverage. There's only one time where I tell people not to enroll in Part A, and that's if they have a health savings account, HSA, that they are currently contributing to, or if their employer is currently contributing to it. There's an IRS regulation there that says you cannot contribute to an HSA when you are actively on Medicare or taking Social Security benefits. And if you're taking Social Security benefits, your Medicare comes automatically. So there's a lot of different things to know here. So generally I say take Part A, even if you're working. There's no reason not to, unless there's an HSA involved, health savings account. And if you want information about that, look up the IRS regulation. If you Google HSA and Medicare IRS, it'll come up. All right, next slide. All right, so here's my poll question. Which of these count as active health insurance? I'm sorry, health insurance through active employment. So we'll go ahead and have that poll question pop up, please.
And Kate, if you could just read the options, it's helpful.
Oh, sure. I'm sorry. A is COBRA, B is retiree health insurance, C is a marketplace plan, D, payment of retiree health coverage via sick leave bank hours, E is all of the above, and the last is none of the above. All right. Okay, so great. So let's go through these options, okay? Now, again, I'm looking for health insurance through active employment, okay? A, COBRA is by definition not active employer coverage. The way that you get COBRA is because you're on FMLA, or you recently quit a job, or you retired, one of those circumstances. COBRA by definition is not active employer coverage. Retiree health insurance is not active employer coverage. I should specify what I mean is you are currently working and your health insurance is from that work. Okay, so retiree health insurance, that tells me you're not currently working. So that is not active employer health insurance. A marketplace plan. Now, I'll give you the example of my dad. My dad worked at a company that had 5 employees for a long time, and they didn't offer health insurance. So he went and got a marketplace plan for insurance, and so he was insured and he was working. But his marketplace plan was just an individual marketplace plan for himself through the marketplace. It was not coverage through active employment because it was not from his job. Now shop plans on the marketplace are different. That, generally speaking, will be active employer coverage, but that's a little bit different. My dad was just on a single policy employer coverage because his employer didn't offer anything. And single policy on the marketplace. So marketplace coverage is not active employer coverage, right? So there are a lot of lawyers that work as a solo practice firm. They might have a marketplace plan. That's not health insurance from active employer coverage because it comes from a different source other than their employer. Payment of retiree health coverage via sick leave bank of hours, right? This is for state employees. We hear about this often. This is not active employer coverage. This is a retiree benefit. It's not active, and they will get a penalty if they don't take Medicare during the 8 months in which they stop actively working. They have an 8-month window. So they have their IEP, which is 3 months in front of their birthday, the month of their birthday, and the 3 months after. That's your initial enrollment period when you turn 65. And then they also have, once they quit working, once they stop active employment or stop active employer health insurance, they have 8 months. And if they don't enroll within 8 months, then they're going to be subject to the general enrollment period that Tiffany talked about, and possibly a late enrollment penalty. And they might have a coverage gap of up to 15 months when they don't have coverage when they would want it, right? If someone comes to me now and says, Kate, I want health insurance coverage through Medicare, I didn't take it when I should have, I'll say, well, you need to enroll in the general enrollment period in January, and your coverage will start July 1, 2022. So they will go from now until July without coverage. And they are not going to qualify for a marketplace subsidy if they get Part A for free. Medicare Part A for free. So generally speaking, they'd either have to pay full price on this marketplace, or they're just going to have to wait it out. And unfortunately, a lot of clients come to us when they have cancer or when they have health issues, and they say, okay, I didn't take Medicare when I should have, but now I want in. And my hands are pretty tied at that situation, unfortunately. So the correct answer here is none of the above are active employer health insurance coverage. And it's really important, again, that we get this right. And we send people to the ADRC or Social Security if it's about Part B enrollment or declining. Thanks. Next slide. Great, thank you.
Okay, hi everybody. I'm Vicki Bugals. I am the Medigap Helpline Services Supervisor at the Board on Aging and Long-Term Care. Next. First, I want to introduce who we are. The Medigap Helpline Services, we've been with the state now since the 1980s. And we do provide statewide counseling for Medicare beneficiaries and other people looking for coverage options around Medicare statewide of all ages, whether they be under age 65 or over 65. We do provide counseling. We've got 7 active counselors at the agency. And like I said, we are statewide. We do work in conjunction with GWAR, with Kate, and with the Aging and Disability Resource Centers in order to make sure that we provide services for a person who may need more hands-on help. We would refer them to the ADRCs, but the ADRCs also refer to us in helping people understand the differences and the types of options that are available. So hang on to this slide, and you'll also have a resource to refer people to. So, but I'm going to talk more about the transitioning from marketplace into Medicare coverage, because that's sometimes a pretty tricky situation for a lot of people, whether they had gotten misinformation from prior people or just out and out confusion. There are some people that may want to delay that Medicare enrollment. Persons who are not taking their Social Security money benefits or their railroad retirement benefits yet, then they may want to hold off. We've had people who wanted to hold off until they've hit their full retirement age, so that way they can pocket maybe a little bit more money in there. And so they may have a marketplace plan, and they may have received a subsidy. They may be paying a very low premium. When they take Medicare, they will automatically lose that tax subsidy, and therefore now we're looking at Medicare costs, and Medicare costs can be much higher than what they were paying with the marketplace plan. We do caution people who are trying to go that route, or if that's what they did already, and then we need to step in, or they call us for help, we need to step in and try to help them understanding the Medicare enrollments and understanding what they can and can't do. And we've had to inform people that, yes, you've earned a penalty because you were not actively working. So there are people who will want to delay, but this is one of the things we caution them on, is that 10% premium penalty for not having an active employer plan to be able to delay Medicare. There are people that would be eligible for ESRD Medicare, end-stage renal disease Medicare, not on a transplant list. Some people may not be on disability Medicare yet. Maybe they're not aged into Medicare yet, but by the fact that they're on dialysis, Typically on the 4th month, they're eligible to sign up for ESRD Medicare. However, the person may have a marketplace plan, pay a much lower premium. They may have met their max out of pocket already for the year. So there are certain times when the person may want to stay in their current coverage and not elect to sign up for ESRD Medicare. Now, according to the Medicare guidelines, this is allowed. This is allowed. So a person can delay ESRD Medicare until we encourage people to make sure they have it at the time of a transplant. And that's because there's some protections involved to help cover immunosuppressive drugs at that time or whenever they're on Medicare. So it's important for them to have ESRD Medicare in place at the time of the transplant. But if the person's in a marketplace plan, they are allowed not to elect Medicare to stay with that marketplace plan. We've had a couple of incidences this past year where the marketplace planner had insisted that the beneficiary had to take ESRD Medicare. They had to sign up for it, and therefore they incurred major out-of-pocket costs because they didn't have to sign up for ESRD Medicare. It took working with the Office Commissioner of Insurance and CMS to go through and understand that whole process better. And that will be on the next slide that I discuss. But another reason also why a person may want to delay sign up for Medicare, if they have not earned those credits, and they would have to pay a premium for Medicare Part A. When you look at the cost of the premium for Part A plus the cost for Medicare Part B, that adds up. And then they would need to have maybe possible secondary coverage to go with Medicare and a drug plan. So they may be much better off staying with a marketplace plan. So this, again, is another situation where the beneficiary may want to delay Medicare if ever they take Medicare in those circumstances. So, and these are things that we do help people look and understand the risks of not taking Medicare, as well as understanding what they have and why they may want to delay Medicare at that time. Next slide. So this is a bulletin that came out this past July. This is a bulletin issued by the Office of the Commissioner of Insurance, OCI, and they clarified Wisconsin as a non-presumptive eligibility state. Non-presumptive Medicare eligibility state, which means just because a person's eligible, that doesn't mean they have to take it. And this clarifies the ESRD portion that a person that's end-stage renal, and I say only because if they're aging in at age 65, receiving their Social Security benefits, or if they're on disability, they're receiving their benefits, Medicare will start automatically. So, and they're not allowed to not take Medicare without paying all that money back. So this is only people that have ESRD Medicare only for this bulletin. So the mandate does not allow an insurer to refuse to provide coverage or pay as a secondary payer, assuming that you have to have Medicare, you're eligible, you have to have it. So I've got the link here, look it up, understand that, and understand that Wisconsin is a non-presumptive Medicare eligibility state. Also, one of the new things that a lot of callers call us about, saying that they're receiving notices, letters from CMS that are telling people you're on a marketplace plan and you're going to be turning 65. It's giving people that heads up that they need to take action before they end up starting to receive Medicare, ending up losing the tax credits, ending up with major out-of-pocket premiums that they owe, or having, when they do their taxes, have it all recouped at that time. So this gives people a heads up in order to understand that they need to take an action at this time, that you're turning 65. And if you're on a marketplace plan, this is a time when you need to review, analyze, and understanding the coverage. So some of the timing has been a little bit tricky. I remember way back when you had to do it by the 15th, so it would be done by the end of the month. But now it looks like once the Medicare start date is determined, the beneficiary may want to plan for when it should end, to avoid having that lapse where they lost their tax credits or have to pay some of it back. But oftentimes we'll find people that are on a household contract. They may be the head of the household or one of the members on that contact sheet losing that coverage. We encourage them to call the Healthcare.gov or talk to a navigator, not just the plan, to ensure that if they drop themselves off because you're starting Medicare, that everybody else in the household doesn't lose their coverage also, because that is one of the areas that we caution them on for them to do. So that is some of the timing and some of the information. So, and then we're going to talk about the risks, some of the risks of keeping the marketplace plan and then becoming eligible for Medicare. They are allowed to do that. However, they lose the tax credits, they lose those cost sharing reductions. Plus, there's no coordination between Medicare and the marketplace plan. So the beneficiary has to be proactive when they have services and Medicare is filed. They need to submit the claims to the marketplace plan themselves. And they may find that they're paying something, something toward duplicate coverage. But either way, so there are some issues with keeping the marketplace plan with Medicare. And I remember a while ago, we had a lot of people keeping their marketplace plan with Medicare, causing a lot of issues, a lot of claim issues. And when we run across claim issues, we do refer them to go back to the ADRCs to work with the folks there so they can work face to face. Because we are primarily at the Medigap helpline a phone system. So, but either way, insurance has gotten quite complex when we're looking at all these different options that are surrounding Medicare or surrounding the marketplace. Thank you. Next.
Hello, thank you. Well, so the vast knowledge that's here. So I am from one of the Aging and Disability Research Centers. I'm here locally in Dane County, but again, we are statewide. Would you mind advancing the screen? Thank you. Well, this is just a brief, because I know with that poll, I definitely got the impression that quite a few of you are already aware of ADRCs and making referrals to ADRCs, which we really appreciate. But specifically what we are is we provide for older adults, individuals with physical, developmental disabilities, caregivers, pretty much, all walks of life you can be coming into the ADRC. And our goal is to help individuals learn about resources in their community so that they can have the life that they are wanting, being able to live independently with supports if they are needing them, to help them connect with those different resources. And this is a slide just as a tool as well for individuals. I'm not necessarily sure if you were all aware with the ADRCs, but this would be able to link you to the phone numbers and hours of the different ADRCs because they can be different. There are some ADRCs that are regional. So maybe they'll have one main office or number that you call for multiple counties. And again, just kind of based on how they work. And could you advance the next one, please? And then this again kind of talks about who we serve. Again, really going to be older adults, individuals dealing with disabilities, individuals with AODA, mental health resources. Again, people who are calling us, we are going to do our best to try to connect you to the right resource. Often we would say, maybe, we aren't going to be the ones who will have all the answers for this. And so let's figure out where you should be going. And this kind of talks about what happens when you contact the ADRC. Often, like what Vicki had mentioned, others their goal really is for there to be no wrong door. So for us, we will have individuals stop in at the ADRC who maybe just got that letter telling them that their marketplace is going to be ending because they're going to be getting Medicare. So they will stop in. And then we try to navigate, what should we do? What's the next thing? Should we give a call? And should we maybe jointly call over to the Medigap helpline to talk through what some of the options are? Is there something going on that maybe a benefit is being denied or something? And then from there, we here at this ADRC, and often the different ADRCs would internally kind of determine, is this something that should go to an elder benefit specialist or a disability benefit specialist? And so that way then we make a referral. So usually with the ADRCs, it is kind of talking with an information and assistance specialist who tries to kind of know that general knowledge about Medicare and how it interacts with the ACA and how it interacts just for individuals out there turning 65 with employer coverage. And then from there, do we need to connect them to an expert? And for us, that would be the Elder Benefit Specialist program through Vicki with the Medigap. But again, it would definitely be kind of no wrong door. And I know one of the questions was asking kind of when to refer. And I would just say for us, the earlier the better, because individuals are able to give us a call and we can really kind of talk through what is going on so they have a sense of what's coming. So maybe it's one of those, well, okay, you aren't going to be turning 65, until next summer. Well, let's at least kind of give some information, talk about what that's going to look like. Then give us a call back when it gets closer to it. So one thing we don't want is that crisis. And I'm not sure if you guys have encountered that, but I know for us, often we would have individuals who will come in and they'll, let us know that they just got this notice like 2 weeks ago and there's a deadline in a week. And so the earlier, the better. So I'm not sure if we have time for any questions or.
Yeah, so if what we can do is wait for a couple more questions to come in and go ahead and type your questions in. I know that we haven't had a ton of time, and the wealth of knowledge represented by panelists, they have been answering those questions. So go ahead and look at those and review them if you have not yet done so.
Stephanie, Tiffany asked me to remind me, like, one big feature that we do is we do benefit checkups too for just about all individuals who will come into an ADRC. And this I know is going to be pretty general for all the ADRCs, is we will sit there, kind of talk with you to see what you might be eligible for. So individuals, especially on the ACA, we're going to go over those Medicare savings programs that Kate had mentioned. We're going to see if there might be other programs out there that you'd be eligible for, food share, Medicaid, different things like that, that help to save costs too. So thank you. Sorry to interrupt.
No, no worries. There is a couple questions. Do you have services for adults that have autism?
And yes, we do. Again, how we would work is we kind of, when we talk to individuals, we get a sense of what kind of help. Is that services for help in the home? and then connecting them to maybe home health, supportive home care agencies. Is it wondering about supported employment? So we kind of navigate from there. So we don't provide the hands-on services, but we more connect you to the right resource and see what you might be eligible for.
Great. And there's another question here. I'll direct to Tiffany. What's the difference between a benefit specialist and a benefits advocate? How can you be both or do both?
I was actually going to see if Kate could answer that.
I don't really understand the question. We have elder benefit specialists and disability benefit specialists at the ADRCs. And so they are advocates for clients. So I'm guessing that those terms are probably used synonymously and or interchangeably. And my guess is it's probably referring to the same thing, unless maybe the person asking the question can give us more information. But a benefits specialist is someone who is really good at looking at someone's benefits and doing benefits counseling, saying when you need to take Medicare, when you don't, looking at, as Abigail was kind of mentioning, screening for other subsidies you might be interested in or eligible for. So I think those are synonymous terms. So we call them elder benefit specialists and disability benefit specialists at the ADRCs, but people can refer to them as a benefits advocate. I mean, essentially that's what they do. So unless there's something else where they're used at a different place, I think it means the same thing.
Great. Tiffany, if you can go ahead and advance to the next slide. I think there should be one more. If not, that's all right. There is one more question. I'll read that in a second. I just want to alert everyone to, it was mentioned in the last presentation, there is a basic how-to sheet for Medicare on the Covering Wisconsin website. So you can find that there. I'll make sure it's posted with this presentation. And two of the individuals here did actually advise on the language and content. And I know that I interviewed Kate to get some of the really important pieces that were included in that. So that is available. And I think it's quite helpful. And it is something you can give directly to a consumer to help get them to start thinking about this process. As you can see with all of the content in this presentation, they have a lot of decisions to make. And it's a lot of complex things that they're going to have to think about. So again, sooner the better. And make sure people really understand how important those deadlines are. No one wants to pay a 10% penalty for every year they delay for the rest of their life. So that's one of the important pieces. And then we'll go to our last question. And I realize we are at the top of the hour. So if you need to drop off, go ahead and do so. We'll just briefly look at the question. I had an individual that I had helped with Marketplace that was turning 65 and had enrolled with Medicare and I think an Advantage plan 3 months prior to his birth month, and thought since he enrolled he could use it and wanted to end his Marketplace coverage early. I was disappointed that the insurance agent that enrolled him in Medicare hadn't explained this better. A comment. Does someone with a disability Medicare move to old age Medicare at any point? Or is it all just the same thing?
I can answer that. Oh, go ahead, Tiffany. Yeah, thank you. Go ahead.
Eeny, meeny, miny, mo. We can all answer that. We all understand. Medicare is Medicare. Whether you have it ESRD Medicare, whether you have by disability, whether you have it by age, doesn't make a difference. The only thing those designations does is tell us your enrollment, how to get into Medicare. Once you got it, covers the same.
Great. Okay, I see that the link to that sheet was posted, and I think we're about ready to wrap up. So I want to thank our panelists. Thank you so much wealth and knowledge. And again, you know, the Medigap helpline and your local ADRC are two great resources to really help your consumers navigate this really complex process. So I want to thank everyone.
Thank you so much to all of the speakers. This is Courtney, and unfortunately, Allison's Zoom has crashed. So I thought I would just close us out for the day by saying thank you to everyone for joining. We will be announcing the winner of today's gift card raffle tomorrow, since Allison will announce that tomorrow morning. And we'll follow up via email if someone is not attending tomorrow but won the raffle. So no worries there. And you'll be receiving the links for tomorrow's session in the morning as you have been, but if not, if you don't get those for any reason, they're always on our website. So thank you, and we will see you tomorrow.
Right. Thank you so much.